Hello everyone, this is Dr. Sam and today you will learn how to write obstetric ultrasound reports. We will be looking at normal reports as well as reports related to pathologies regarding pregnancy. We will study each area one by one, such as fetal brain, fetal stomach, fetal kidneys, etc. The reports will include the findings section and the impression section. Some reports will also include a recommendations section. First, we will start with normal early pregnancy and first trimester ultrasound reports. These will be full obstetric ultrasound reports. We are starting with a 5-week pregnancy obstetric ultrasound report. In this case, the age is 29. Gestational age is 5 weeks by LMP. Gravida is 1. Gravida is the number of pregnancies and para is the number of births. So for this patient, this is the first pregnancy, gravida 1, and this patient had no previous birth or any previous pregnancy. That is why para is 0. After writing the patient information, you can write the findings, starting with the uterus. In this example, the uterus is anteverted, normal in size and echo texture. Then you can write about the endometrium. During pregnancy, it is thickened and echogenic, consistent with early pregnancy, no abnormalities detected. Then you can write about the gestational sac, starting with its location, intrauterine, located in the fundus. Then you can write the size, the MSD, mean sac diameter. In this example, it is 5.5 millimeters in diameter. After that, you can write about its shape. It is round, regular, and well defined. The yolk sac is not visualized at 5 weeks, and the fetal pole or embryo is not visualized at 5 weeks. So you can write not yet visualized. Then you can write about the ovaries and adnexa. Right ovary, normal in size and echo texture. You can also write the size of the ovary, the measurements. The left ovary is also normal in size and echo texture. A small corpus luteum cyst is noted, measuring 10 millimeters, which is typical in early pregnancy. Adnexa is normal. No free fluid or masses observed. After writing all the findings, you can proceed with the impression. It is the conclusion of the ultrasound scan and includes the main findings. Intrauterine pregnancy consistent with 5 weeks of gestation. The gestational sac is appropriately visualized for this gestational age. The yolk sac and fetal pole are not yet visible, which can be normal at this stage. A follow-up ultrasound is recommended in 1 to 2 weeks to assess for the development of the yolk sac and fetal pole. This next report is of a 6-week pregnancy. Age 29, gestational age is 6 weeks by LMP, gravida 1, para 0. These are the findings. The uterus is anteverted, normal in size and echo texture. The endometrium is thickened and echogenic, consistent with early pregnancy. These are the findings of the gestational sac. Location is intrauterine, positioned in the fundus. Size 12 millimeters in diameter. This is the mean sac diameter. Shape is round, regular, and well defined. These are the yolk sac findings. Location within the gestational sac. Size 4.5 millimeters in diameter. Appearance is normal with a smooth contour. The yolk sac is usually seen at 6 weeks. The fetal pole is also present at 6 weeks. So these are the findings. Location present within the gestational sac, size 2 millimeters. Then you can write about fetal heartbeat, which is usually not present at 6 weeks. Detection not yet visualized, may be too early at 6 weeks. Follow-up in 1 to 2 weeks recommended. After that you can write about the ovaries and adnexa. And this is the impression: intrauterine pregnancy consistent with 6 weeks of gestation. The gestational sac, yolk sac and fetal pole are appropriately visualized. The fetal heartbeat was not detected at this stage, which is not uncommon. A follow-up ultrasound in 1 to 2 weeks is recommended to assess fetal development and confirm the fetal heartbeat. This is a 7-week pregnancy ultrasound report, starting with the patient information. Here are the findings of the gestational sac. Location intrauterine, located in the fundus. Size 20 millimeters in diameter. This is the mean sac diameter. Shape round, regular and well defined. These are the yolk sac findings. Location within the gestational sac. Size 5 millimeters in diameter. Appearance is normal. Here are the fetal pole findings. Crown rump length can be measured. The CRL is 8 millimeters. Appearance is normal for gestational age, with appropriate development observed. Fetal heartbeat is present at 7 weeks. Detection present. Heart rate 140 beats per minute, which is normal for this gestational age. Rhythm is regular. Then the findings of the ovaries and adnexa are written. Here is the impression: intrauterine pregnancy consistent with 7 weeks of gestation. The gestational sac, yolk sac, fetal pole, and fetal heartbeat are appropriately visualized. The fetal heartbeat is within normal range, indicating a viable early pregnancy. Schedule the first trimester screening at 11 to 14 weeks gestation. Now we have an 11-week pregnancy ultrasound report. These are the findings. The uterus is anteverted and normal. The CRL is 44 millimeters, consistent with 11 weeks of gestation. Cardiac activity: fetal heart rate is 165 beats per minute, which is normal. Fetal movement: normal movement observed. At 11 weeks, we can write about the fetal anatomy, starting with the head, appropriate size and shape for gestational age, limb buds, upper and lower limb buds present and developing normally. Spine has normal alignment with no visible defects. Abdomen properly closed with no abnormalities noted. Nuchal translucency measured at 1.5 millimeters, within normal limits for gestational age. Then you can write about the placenta. These are just examples of reports. Not all findings are matching with the images shown above. The placenta in this case is anterior, high-lying, maturity grade 0, appropriate for gestational age. Amniotic fluid volume is normal. Then you can write about the ovaries and adnexa. This is the impression: single live intrauterine pregnancy consistent with 11 weeks of gestation, normal fetal anatomy and development noted, with a strong and regular fetal heartbeat. Nuchal translucency is within normal limits. No maternal or fetal abnormalities observed. Schedule the next ultrasound for the second trimester anatomy scan at 18 to 20 weeks. This is a 12-week pregnancy ultrasound report. These are the findings in the fetus. Crown rump length 56 millimeters. Fetal heart rate 160 beats per minute. Rhythm is regular and strong. Fetal movements. Active fetal movements observed, including limb and body movements. These findings are of the fetal anatomy. Head normal size and shape. Cranial ossification present. Face, nasal bone visualized, normal appearance. Limb buds. Upper and lower extremities are present with appropriate development. Hands and feet identified. Spine well aligned with no visible defects. Abdomen normal abdominal wall closure with no herniation. Nuchal translucency measured at 1.8 millimeters within normal limits. Placenta is posterior, not previa. Grade 0. Amniotic fluid is normal. Then the findings of the ovaries and adnexa are written. This is the impression. Single live intrauterine pregnancy consistent with 12 weeks of gestation. Fetal anatomy including the nuchal translucency and nasal bone is within normal limits. Fetal heart rate and movements are normal. No maternal or fetal abnormalities detected. Schedule the next ultrasound for the second trimester anatomy scan at 18 to 20 weeks. These are ultrasound reports regarding ectopic pregnancy. The first report is about the most common type of ectopic pregnancy, the tubal ectopic pregnancy. This is the patient information, age 28 years, gravida 2, para 0, LMP 6 weeks ago. Presenting complaint, lower abdominal pain and vaginal spotting. Clinical indication, suspected ectopic pregnancy due to positive pregnancy test and clinical symptoms. These are the findings: uterus, normal size and shape, endometrial thickness 10 millimeters, no intrauterine gestational sac visualized. These are the findings of the right adnexa. Presence of a complex adnexal mass measuring 3.5 into 3 centimeters. The mass is separate from the ovary and contains a gestational sac with a yolk sac. No fetal pole or cardiac activity detected. Left adnexa, normal appearance of the left ovary and no adnexal masses or free fluid. Cul-de-sac, small amount of free fluid noted, suggestive of hemoperitoneum. This is the impression. Findings are consistent with a right tubal ectopic pregnancy. Recommendations: immediate referral to the obstetrics and gynecology department for further management. It is an emergency case, so immediate referral is important. This is a report about interstitial ectopic pregnancy. This is the patient information, 32 years old, gravida 4, para 1, LMP 8 weeks ago, presenting complaint, severe lower abdominal pain and vaginal bleeding. These are the findings of the uterus, normal size and shape, endometrial thickness 11 millimeters, no intrauterine gestational sac visualized. Right adnexa, normal appearance of the right ovary, no adnexal masses or free fluid. Left adnexa, normal appearance of the left ovary, no adnexal masses or free fluid. You can write a separate section called interstitial region. These are the findings: presence of a gestational sac located in the interstitial portion of the fallopian tube. It is the part of the fallopian tube that opens up into the uterus. The sac contains a yolk sac and a fetal pole. The fetal pole measures 7 mm with no cardiac activity detected. In the cul-de-sac, moderate amount of free fluid noted, suggestive of hemoperitoneum. This is the impression. Findings are consistent with an interstitial ectopic pregnancy with a visualized fetal pole. Immediate referral to the obstetrics and gynecology department is advised. Now we have a report of cervical ectopic pregnancy. These are the findings of the uterus. It is normal. The endometrial thickness is 10 mm. There is no intrauterine gestational sac. The patient had a positive pregnancy test. These are the findings of the cervix. Presence of a gestational sac located within the cervical canal. The sac contains a yolk sac and a fetal pole. Fetal pole measures 5 mm with no cardiac activity detected. These are the findings of the adnexa. Both the right and left adnexa are normal. In the cul-de-sac, there is moderate amount of free fluid, suggestive of hemoperitoneum. This is the impression. Findings are consistent with a cervical ectopic pregnancy with a visualized fetal pole. Immediate referral is advised. This report is about ovarian ectopic pregnancy. The findings of the uterus are normal. Right adnexa, the right ovary is normal. No adnexal masses or free fluid are noted. Left adnexa, presence of a complex adnexal mass measuring 3.8 into 3.2 centimeters. The mass is located within the left ovary and contains a gestational sac with a yolk sac and a fetal pole. Fetal pole measures 5 mm without cardiac activity. Cul-de-sac, minimal amount of free fluid noted. This is the impression. Findings are consistent with a left ovarian ectopic pregnancy with a visualized fetal pole. Immediate referral is recommended. A heterotopic pregnancy is extremely rare. These are the findings in this case. Intrauterine gestational sac visualized with a yolk sac and fetal pole. Fetal pole measures 8 mm with cardiac activity. In a heterotopic pregnancy, there will be coexisting intrauterine and extrauterine pregnancies. One gestational sac will be intrauterine and the second gestational sac will be ectopic. In this case, it was present in the cervix. These are the findings of the cervix. Presence of a gestational sac located within the cervical canal. The sac contains a yolk sac and a fetal pole. Fetal pole measures 6 mm with no cardiac activity detected. Both the ovaries are normal. There is minimal amount of free fluid in the cul-de-sac. This is the impression. Findings are consistent with a heterotopic pregnancy with one gestational sac within the uterine cavity and another within the cervical canal. Recommendations: immediate referral to the obstetrics and gynecology department for further management. These ultrasound reports are related to miscarriage. The first report is about threatened miscarriage. This is the patient information. Gestational age is 8 weeks 2 days. Indication: vaginal spotting and lower abdominal cramping. These are the findings of the uterus. The uterus is anteverted and measures approximately 8.2 into 4.5 into 5.3 centimeters. The endometrial stripe is consistent with early pregnancy. There is no evidence of fibroids or other uterine abnormalities. Gestational sac: a single intrauterine gestational sac is present. Fetal pole: a fetal pole is visualized within the gestational sac. Crown rump length measures 11 millimeters, corresponding to a gestational age of 7 weeks 6 days. Fetal heart rate: a fetal heartbeat is detected with a heart rate of 75 beats per minute. This is below the normal range for gestational age. At 8 weeks, it is expected to be between 120 to 160 beats per minute. Cervix: the cervical length measures 3.5 centimeters, which is within normal range. No evidence of cervical funneling or dilation is observed. Impression: threatened miscarriage due to low fetal heart rate of 75 bpm, which is concerning for possible fetal demise or non-viability. Gestational age is consistent with early pregnancy, but CRL measurements are slightly less than expected for gestational age by LMP. Recommendations: close follow-up with repeat ultrasound is recommended within 1 week to assess for interval changes in fetal heart rate and growth. This is another report of threatened miscarriage. Gestational age is 7 weeks 5 days. Clinical indication: vaginal bleeding and lower abdominal cramping. These are the findings. The uterus is anteverted and its size is written. No uterine masses or fibroids are noted. Gestational sac: a single intrauterine gestational sac is visualized, measuring 18 millimeters in diameter. This is the mean sac diameter. The gestational sac is irregularly shaped with some asymmetry and mild distortion of its walls. This finding is concerning for a potential non-viable pregnancy or poor implantation. Fetal pole: a fetal pole is present and measures 9 millimeters in CRL, corresponding to approximately 7 weeks 2 days. Fetal heart rate: a fetal heartbeat is detected, but the fetal heart rate is bradycardic at 80 beats per minute. This is significantly below the normal range, raising concerns for possible fetal demise. Cervix: the cervix measures 3.4 centimeters in length, with no evidence of dilation or funneling. The internal os is closed. At DEXA, both the ovaries are visualized and appear normal in size and morphology. There is no evidence of adnexal masses or free fluid in the pelvis. This is the impression: threatened miscarriage with findings of fetal bradycardia and irregularly shaped gestational sac. The irregular contour of the gestational sac and low fetal heart rate are concerning for a non-viable pregnancy. Recommendations: repeat ultrasound in 7 to 10 days to assess for interval changes in fetal growth and heart rate. This is a report for missed miscarriage. Gestational age 9 weeks 0 days. The uterus is normal and its size is written. No fibroids or masses are noted. Gestational sac. A single intrauterine gestational sac is visualized. The gestational sac measures 28 millimeters in diameter, corresponding to approximately 8 weeks 5 days. However, the sac appears empty with no fetal pole, yolk sac, or embryo visualized. This is consistent with a diagnosis of an embryonic pregnancy, blighted ovum. The gestational sac has regular contours and there is no evidence of subchorionic hemorrhage or other abnormalities. The cervical length is 3.6 centimeters. The internal os is closed. There is no evidence of cervical dilation. Both the ovaries are normal in size and appearance. This is the impression, missed miscarriage, and embryonic pregnancy with an empty gestational sac measuring 28 millimeters, consistent with 8 weeks 5 days gestation, but no evidence of an embryo or fetal development. Findings are consistent with a failed early pregnancy. Follow up with obstetrics to decide on the best course of action. This is a case of inevitable miscarriage. Gestational age is 10 weeks 1 day. Indication: heavy vaginal bleeding and severe lower abdominal cramping. These are the findings of the uterus. The uterus is normal. Gestational sac. A single intrauterine gestational sac is present, measuring 30 millimeters in diameter, corresponding to approximately 9 weeks 2 days. The gestational sac is located low in the uterine cavity near the internal os, indicating impending passage through the cervix. Fetal pole. A fetal pole is visualized measuring 22 millimeters in crown rump length, consistent with a gestational age of 9 weeks. No fetal heart activity is detected. The cervix is dilated to 1.5 centimeters with visible products of conception noted near the cervical canal. This finding, combined with heavy bleeding, indicates that miscarriage is imminent. Both the ovaries are normal. This is the impression, inevitable miscarriage with findings of cervical dilation 1.5 centimeters and products of conception in the cervical canal. No detectable fetal heartbeat. Low positioning of the gestational sac, indicating impending passage. Recommendations: patient to be monitored for excessive bleeding or infection. This is a report regarding incomplete miscarriage, gestational age 10 weeks 4 days. Clinical indication: heavy vaginal bleeding and passage of tissue. The uterus is anteverted, the myometrium is homogeneous, and no uterine fibroids or other abnormalities are identified. The endometrial cavity contains heterogeneous echogenic material measuring approximately 24 millimeters in the anteroposterior dimension, suggesting retained products of conception. No clear gestational sac is visualized, consistent with partial expulsion of pregnancy tissue. The cervix is partially open, measuring approximately 1 centimeter in dilation. There is no significant funneling noted. Both ovaries are visualized and appear normal. This is the impression: incomplete miscarriage with evidence of retained products of conception and a partially open cervix. The majority of pregnancy tissue has likely been expelled, but residual tissue remains in the uterine cavity. These ultrasound reports will focus on fetal brain pathologies. The first report is a normal obstetric ultrasound report. The fetal brain was normal. In this example, gestational age is 28 weeks 3 days. Indication: routine follow-up, normal pregnancy. These are the findings: fetal position and lie, cephalic presentation, spine anterior. This is the fetal biometry. All the values are within normal range. These are the findings of the fetal brain. The fetal brain findings are more in detail because we are focusing on the fetal brain. So you will learn here how to write detailed findings regarding fetal brain pathologies. Lateral ventricles, normal, measuring 6.5 millimeters in width. No evidence of ventriculomegaly. Cavum septi pellucidi, present and normal. Third ventricle, normal in size. Cerebellum, measures 30 millimeters in transverse diameter, consistent with gestational age. Posterior fossa, cisterna magna, 5 millimeters, within normal limits. Choroid plexus, symmetric, without cysts or masses. Falx cerebri, intact, midline. No evidence of intracranial hemorrhage, mass effect, or structural abnormalities. Other anatomical survey. No abnormalities noted in the remaining structures of the fetal head and neck. Amniotic fluid index 12 centimeters, within normal range. Placenta posterior, grade 1, not low-lying. Umbilical cord, 3-vessel cord with normal Doppler waveforms. Cervical length 3.5 centimeters, closed. This is the impression. The ultrasound reveals a single live intrauterine fetus at 28 weeks and 3 days. All measurements and anatomical findings are consistent with the gestational age. Now we will see reports regarding fetal brain pathologies. The first one is mild ventriculomegaly. This is the report. Gestational age 22 weeks 5 days. Indication: anomaly scan, follow-up for suspected ventriculomegaly. These are the findings. Fetal biometry, it is normal. These are the fetal brain findings. Lateral ventricles, mildly dilated bilaterally. The atrium of the lateral ventricles measures 11.5 millimeters on the left and 10.8 millimeters on the right. Upper limit of normal is 10 millimeters. Cavum septi pellucidi, present and normal. Third ventricle, normal in size. Cerebellum measures 22 millimeters in transverse diameter, consistent with gestational age. Posterior fossa, cisterna magna, 5 millimeters, within normal limits. Choroid plexus, normal, no cysts or masses. Falx cerebri, intact and midline. No evidence of other intracranial abnormalities such as masses, hemorrhage, or abnormal calcifications. Other anatomical survey, no abnormalities noted in the remainder of the fetal anatomy. AFI, 14 centimeters, which is within normal range. Placenta anterior, grade 1, not low-lying. Umbilical cord, 3-vessel cord, normal Doppler waveforms. Cervical length 3.8 centimeters, closed. This is the impression. Mild bilateral ventriculomegaly is noted. No other structural abnormalities are identified. This finding warrants follow-up to assess progression or resolution and to exclude associated anomalies. Repeat ultrasound in 4 weeks to monitor ventricular size. Now we have a report of moderate ventriculomegaly. Only the findings related to the fetal brain and any other abnormal findings, if present, will be written. The normal findings are removed to avoid repetition because we are only focusing on the fetal brain pathologies. These are the findings: lateral ventricles, moderate dilated bilaterally. The atrium of the lateral ventricles measures 12.5 millimeters on the left and 12.1 millimeters on the right. Cavum septi pellucidi present and normal. No evidence of additional intracranial abnormalities such as hemorrhage, mass effect, or abnormal calcifications. No structural abnormalities identified in the remainder of the fetal anatomy. This is the impression. Moderate bilateral ventriculomegaly is observed with measurements exceeding 12 millimeters. The remaining fetal brain structures and other anatomical findings are within normal limits. The significance of moderate ventriculomegaly includes the potential for progressive ventricular dilation or associated anomalies. Further evaluation is recommended. This is a report of aqueductal stenosis. These are the findings of the fetal brain. Lateral ventricles significantly dilated bilaterally. Atrial width of the lateral ventricles measures 18 millimeters on the right and 19 millimeters on the left, indicating severe ventriculomegaly. Third ventricle is mildly dilated. Fourth ventricle is normal in size and morphology. Aqueduct of Sylvius, not directly visualized, however, findings are consistent with aqueductal stenosis, leading to the dilation of the lateral and third ventricles with normal fourth ventricle. Cerebral parenchyma, no evidence of cortical thinning or significant parenchymal abnormalities. Cisterna magna is normal in size. This is the impression. Severe bilateral ventriculomegaly. Marked dilation of the lateral ventricles is present. The third ventricle is also mildly dilated, while the fourth ventricle appears normal, suggesting aqueductal stenosis as the likely cause of the ventriculomegaly. The findings are consistent with aqueductal stenosis, which is causing obstructive hydrocephalus with resultant dilation of the lateral and third ventricles. This is the case of hydranencephaly. These are the fetal brain findings. Absent cerebral hemispheres with the replacement of the brain parenchyma by cerebrospinal fluid. The thalami and brainstem are present, but the absence of cerebral cortex, midline structures, and falx cerebri is noted. The cranial vault appears normally formed, but the brain tissue is largely absent, with a fluid-filled cavity occupying the space. The findings are consistent with hydranencephaly. This is the impression. The ultrasound findings are indicative of hydranencephaly, a severe congenital abnormality characterized by the near-complete absence of the cerebral hemispheres, which are replaced by the fluid. The thalami, brainstem, and cerebellum are typically present, and the cranium is intact. This condition is incompatible with life outside the uterus. Other fetal structures appear normal for gestational age. Further imaging, such as MRI, is advised for additional confirmation. These are the recommendations. Given the severity of this condition, early consultation with a multidisciplinary team, including neonatology and palliative care, is highly recommended. Here is a report of porencephaly. These are the findings of the fetal brain. Multiple cystic spaces are noted within the cerebral parenchyma, predominantly in the bilateral frontal and parietal lobes. The cystic lesions vary in size, with the largest measuring approximately 3 cm into 2.8 cm. The cysts appear to communicate with the lateral ventricles, which are mildly dilated. There is thinning of the surrounding brain tissue, but no significant midline shift is observed. The overall shape and size of the cranium are within normal limits for gestational age. These findings are consistent with porencephaly with multiple cystic spaces, suggesting a multifocal insult to the brain. Here is the impression. The ultrasound findings reveal porencephaly characterized by multiple cystic spaces within the cerebral parenchyma. The cysts are likely due to multifocal brain injury, with evidence of communication with the lateral ventricles and associated mild ventriculomegaly. Other fetal structures, including the face, spine, thorax, abdomen, and limbs, appear normal for gestational age. Recommendations: immediate referral to a maternal fetal medicine specialist for detailed counseling regarding the prognosis and management options. Consideration of fetal MRI to further delineate the extent of brain involvement and better characterize the cystic spaces. Close monitoring of the fetal growth and well-being for the remainder of the pregnancy. This is a report of closed lip schizencephaly. Findings: cranial anatomy. The fetal cranium is intact. The cerebral hemispheres are visualized and show the presence of multiple clefts in the right hemisphere, suggestive of schizencephaly. The clefts extend from the ventricles and cerebral cortex to the subarachnoid space. There is mild ventriculomegaly observed, with the right lateral ventricle measuring 10.5 and left ventricle measuring 10.7 millimeters. This is the impression. The fetal ultrasound reveals right-sided closed-lipped schizencephaly with multiple clefts in the right cerebral hemisphere. The remainder of the fetal anatomy appears normal for gestational age. A follow-up MRI is recommended for further evaluation of the extent of the clefts and to assess for associated abnormalities. This is a report of open lip schizencephaly. Findings of cranial anatomy. The fetal cranium is intact. The cerebral hemispheres are visualized and show the presence of multiple clefts, suggestive of schizencephaly. The clefts are bilaterally symmetrical and are consistent with open lip schizencephaly. They extend from the lateral ventricles to the cortical surface, with clear communication between the ventricles and the subarachnoid space. There is significant communication between the lateral ventricles and the subarachnoid space, leading to prominent bilateral ventriculomegaly, with the lateral ventricles measuring 15 millimeters. The septum pellucidum is absent, a finding often associated with schizencephaly. This is the impression. The fetal ultrasound reveals bilateral open lip schizencephaly with clefts having open communication with the lateral ventricles and subarachnoid space, resulting in significant ventriculomegaly. The absence of the septum pellucidum is also noted. Recommendations: a follow-up MRI is recommended for further evaluation of the extent of the clefts and to assess for associated abnormalities. Discuss findings with a pediatric neurologist. Here is a report of arachnoid cyst. Findings: fetal brain. The fetal cranium is intact. The cerebral hemispheres are visualized. A cystic lesion is identified in the left parietal region of the brain, consistent with an arachnoid cyst. The cyst measures approximately 18 into 12 into 9 millimeters respectively. The cyst is located within the left parietal region, causing mild displacement of adjacent brain structures, including a slight shift of the midline structures to the right. No evidence of associated hydrocephalus, with the lateral ventricles measuring 8 millimeters in width within normal limits. The posterior fossa structures, including the cerebellum and cisterna magna, appear normal. This is the impression. The fetal ultrasound reveals the presence of a left-sided arachnoid cyst located in the left parietal region. The cyst is causing mild displacement of adjacent brain structures, but is not associated with hydrocephalus or other significant intracranial abnormalities. A follow-up MRI is recommended for further evaluation of the cyst size, location, and potential impact on surrounding brain structures. Here is a report of choroid plexus cyst. Findings of the fetal brain. The fetal cranium is intact and the cerebral hemispheres are well visualized. Bilateral choroid plexus cysts are identified within the lateral ventricles. The cyst on the right measures approximately 6 millimeters in diameter, and the cyst on the left measures approximately 5 millimeters in diameter. The lateral ventricles are normal in size, with a width of 7 millimeters, which is within normal limits for this gestational age. No evidence of ventriculomegaly or other intracranial abnormalities. The posterior fossa structures, including the cerebellum and cisterna magna, appear normal. This is the impression. The fetal ultrasound reveals bilateral choroid plexus cysts within the lateral ventricles. These cysts are isolated findings, and no other structural abnormalities are noted. Routine obstetric care and continued monitoring are advised. This is a case of alobar holoprosencephaly. Findings: cranial anatomy. The fetal cranium is abnormal with significant structural anomalies. Alobar holoprosencephaly is identified, characterized by a single midline monoventricle without any division into distinct cerebral hemispheres. The thalami are fused, and no falx cerebri or interhemispheric fissure is present. The normal midline structures, including the cavum septum pellucidum and corpus callosum, are absent. Severe facial abnormalities are noted, including the presence of a proboscis located above the fused orbits. Cyclopia is observed with a single midline orbit containing fused eye structures. No evidence of normal posterior fossa structures. Cerebellum and other posterior structures are either absent or severely deformed. These are the findings of the fetal face. The facial profile is abnormal with notable deformities. A proboscis is identified, located superior to the single midline orbit. Cyclopia, characterized by a single midline orbital structure, is present. The nose and other facial features are malformed or absent. Spine. The spine appears structurally intact with normal ossification of the vertebral bodies. No evidence of spinal dysraphism or other spinal abnormalities. Thorax. The fetal heart is visualized within the thorax with a regular rhythm, but detailed cardiac evaluation is limited by the presence of craniofacial abnormalities. Lungs appear normal in echogenicity and size, though lung development may be compromised due to associated anomalies. Abdomen. The stomach, kidneys, bladder, and bowel are normal. The umbilical cord insertion into the fetal abdomen is normal. Extremities. All four limbs are present with normal movement. Hands and feet appear normal. Anterior placenta with normal thickness, no evidence of placental abruption or previa. Amniotic fluid index is 12 centimeters. Doppler studies. Umbilical artery Doppler shows normal flow with no evidence of increased resistance. This is the impression. The fetal ultrasound reveals severe craniofacial and cerebral abnormalities consistent with alobar holoprosencephaly, characterized by a single midline ventricle, fused thalami, and the absence of normal midline brain structures. Associated with these findings are significant facial anomalies, including cyclopia and a proboscis. The prognosis for this condition is extremely poor, with a high likelihood of perinatal mortality or severe neurodevelopmental impairment if the fetus survives to term. A multidisciplinary consultation, including maternal fetal medicine, neonatology, genetics, and pediatric neurology, is strongly recommended to discuss the implications, prognosis, and management options. This is a report of semilobar holoprosencephaly. These are the findings of the cranial anatomy. The fetal cranium is visualized with significant structural abnormalities. Semilobar holoprosencephaly is noted, characterized by partial fusion of the cerebral hemispheres. The anterior portion of the brain contains a single large ventricle, while the posterior brain shows partial separation of the hemispheres. The interhemispheric fissure and falx cerebri are absent in the anterior regions, but are present posteriorly. The thalami are partially fused, and the corpus callosum is either absent or severely hypoplastic. The cavum septum pellucidum is absent. Face hypotaylorism is observed with closely spaced orbits. A proboscis, a tubular-shaped structure, is visualized in the midline, located above the fused orbits. The nose is absent, and no distinct nasal structures are identified. The mouth and chin appear normal. No cleft lip or palate is noted. This is the impression. The fetal ultrasound reveals findings consistent with semilobar holoprosencephaly, characterized by partial fusion of the cerebral hemispheres and associated with significant craniofacial abnormalities. The facial abnormalities include hypotaylorism and the presence of a proboscis with an absence of normal nasal structures. This is a case of lobar holoprosencephaly. Findings: cranial anatomy. The fetal cranium is intact with the presence of cerebral anomalies. Lobar holoprosencephaly is identified, characterized by partial separation of the cerebral hemispheres. The frontal lobes show incomplete division, while the occipital and temporal lobes are mostly separated. A partially formed interhemispheric fissure is present with a rudimentary falx cerebri. The thalami are separated, but the corpus callosum is hypoplastic in the anterior region. The cavum septum pellucidum is absent. Ventricular configuration is abnormal, with a large anterior ventricle. Mild ventriculomegaly is noted, with the lateral ventricles measuring 11 mm in width. The posterior fossa structures, including the cerebellum and cisterna magna, appear normal. Face. The facial profile is normal, no evidence of midline facial defects. The orbits are normally spaced, and the nasal structures appear normal. There is no evidence of hypotaylorism. Impression. The fetal ultrasound reveals findings consistent with lobar holoprosencephaly, characterized by partial separation of the cerebral hemispheres and hypoplasia of the anterior corpus callosum. The thalami are separated and the posterior brain structures appear normal. The prognosis varies depending on the severity of the brain malformation and associated anomalies, but may include significant neurodevelopmental challenges. A multidisciplinary consultation is advised. This is a case of agenesis of corpus callosum. Findings: cranial anatomy. The fetal cranium is intact, but significant intracranial anomalies are identified. The corpus callosum is absent, with no evidence of the normal bridging structure between the cerebral hemispheres. Colpocephaly. Marked dilation of the occipital horns of the lateral ventricles is noted, consistent with colpocephaly. The anterior horns of the lateral ventricles are relatively small, giving the ventricles an abnormal teardrop shape. Interhemispheric cyst. A cystic structure is identified in the midline, located within the interhemispheric fissure. The cyst measures approximately 12 mm in diameter and does not appear to communicate with the lateral ventricles. The third ventricle appears mildly enlarged, measuring 4 mm in width. The thalami are normally positioned and appear normal. The posterior fossa structures appear normal. Impression. The fetal ultrasound reveals findings consistent with agenesis of corpus callosum associated with colpocephaly and the presence of an interhemispheric cyst. Consider further imaging with fetal MRI for a detailed assessment of the brain structures. This is a report of anencephaly. Findings: cranial anatomy. The ultrasound reveals the absence of the cranial vault and cerebral hemispheres consistent with anencephaly. There is an absence of the skull above the orbits with exposed brain tissue, exencephaly, that appears amorphous and poorly formed. The orbits and facial structures are present but appear deformed due to the lack of an overlying cranial structure. The brainstem and portions of the midbrain may be present but are significantly underdeveloped. Face. The facial profile shows severe abnormalities due to the absence of the cranial vault. The orbits are prominent due to the lack of overlying bone structures. No evidence of a cleft lip or palate. However, detailed facial anatomy assessment is limited by the severe cranial anomaly. Impression. The ultrasound findings are consistent with anencephaly. The prognosis is extremely poor with no chance of survival beyond the perinatal period. Immediate referral to a maternal fetal medicine specialist for further counseling is recommended. Now we have a case of encephalocele. Findings: cranial anatomy. The fetal cranium is visualized with evidence of a cranial defect. Encephalocele. A defect in the occipital bone is noted, measuring approximately 15 millimeters in diameter. A sac-like protrusion is seen extending from this defect, containing brain tissue, consistent with an encephalocele. The encephalocele is primarily occipital in location, though it may involve part of the posterior fossa structures. The cerebral hemispheres otherwise appear normal in size, but detailed evaluation is limited due to the presence of the encephalocele. Impression: the ultrasound findings are consistent with an occipital encephalocele, characterized by a defect in the occipital bone with herniation of brain tissue through the defect. Further imaging and detailed assessment, including possible fetal MRI, are recommended to evaluate the extent of the encephalocele and associated brain structures. This is a report of Dandy-Walker malformation. Findings: cranial anatomy. The posterior fossa is markedly enlarged. A large cystic structure is noted in the posterior fossa, consistent with an enlarged cisterna magna which communicates with the fourth ventricle. The cerebellar vermis is hypoplastic or absent, with upward displacement of the tentorium. The cerebellar hemispheres appear widely splayed. The lateral ventricles are severely dilated, measuring 18 millimeters at the level of the atria, consistent with severe ventriculomegaly. The third ventricle is also dilated, measuring 7 millimeters in width. The cerebral hemispheres appear thinned due to the extensive dilation of the ventricles. The cavum septum pellucidum is not well visualized, likely due to the degree of ventriculomegaly. This is the impression. The ultrasound findings are consistent with Dandy-Walker malformation, characterized by an enlarged posterior fossa, cystic dilation of the fourth ventricle, and hypoplasia or absence of the cerebellar vermis. Severe ventriculomegaly is present, with significant dilation of the lateral and third ventricles, causing thinning of the cerebral cortex. Recommendations: consideration of fetal MRI for detailed assessment of the brain structures and further clarification of the diagnosis. This is a report of vein of Galen malformation. Findings: the lateral ventricles are slightly enlarged, measuring 12 millimeters in width. The corpus callosum and cerebellum appear normal. There is a midline pulsatile structure noted within the posterior aspect of the fetal brain. Color Doppler imaging reveals a large, high-flow vascular structure in the midline, posterior to the thalamus, consistent with a vein of Galen malformation. The malformation is seen as an aneurysmal dilatation of the vein of Galen, with turbulent blood flow observed on spectral Doppler. Heart. The four-chamber view of the heart is normal, but there is mild cardiomegaly. There is no evidence of structural heart defects. However, the heart appears to be slightly larger than normal, likely secondary to high output cardiac failure due to the vein of Galen malformation. Impression: the ultrasound findings are suggestive of a vein of Galen malformation characterized by an aneurysmal dilatation of the vein of Galen with associated high-flow arteriovenous shunting. There is mild ventriculomegaly and cardiomegaly, which may indicate the early stages of cardiac overload. Follow-up ultrasound in 2 weeks to monitor fetal growth, amniotic fluid levels, and the progression of the malformation. This is a case of intraventricular hemorrhage. Findings: cranial anatomy. The lateral ventricles are asymmetrical. The right lateral ventricle is dilated, measuring 12 millimeters in width, larger than the left, which measures 9 millimeters. Within the right lateral ventricle, there is evidence of echogenic material consistent with intraventricular hemorrhage. The hemorrhage appears to involve the right choroid plexus and extends into the ventricular cavity. Impression: the ultrasound findings are indicative of a right intraventricular hemorrhage with associated ventriculomegaly. The presence of echogenic material within the right ventricle is consistent with blood, likely originating from the choroid plexus. Recommendations: follow-up ultrasound in 1 to 2 weeks to monitor the progression of the hemorrhage, ventricular size, and overall fetal well-being. This is a case of CMV infection. These are the findings. The lateral ventricles are mildly dilated, with the right ventricle measuring 12 millimeters and the left ventricle measuring 11 millimeters. Periventricular echogenicities are noted, raising concern for periventricular calcifications, which are commonly associated with congenital CMV infection. The cerebellum and corpus callosum appear normal. There is no evidence of intracranial hemorrhage or significant ventriculomegaly. Abdomen: the liver is slightly enlarged hepatomegaly with a homogeneous echo texture. Echogenic foci are noted in the liver parenchyma, suggestive of hepatic calcifications. The spleen is also mildly enlarged, which is splenomegaly. Mild ascites is detected. This is the impression. The ultrasound findings are suggestive of congenital CMV infection characterized by mild ventriculomegaly, periventricular echogenicities, and hepatic calcifications. The presence of hepatosplenomegaly and mild ascites further supports the diagnosis. These findings indicate a possible impact on fetal development, and close monitoring is recommended. This is a report of KRE2 malformation. These are the findings of the cranium. The fetal head shows a lemon-shaped skull characterized by a frontal bone scalloping, a feature suggestive of KRE2 malformation. The cerebellum appears displaced downward and elongated, forming a banana sign due to herniation into the upper cervical canal. The right lateral ventricle is mildly dilated, measuring 10.6 millimeters, and the left ventricle is measuring 9 millimeters. The cisterna magna is obliterated, consistent with the diagnosis of KRE2 malformation. Spine: there is an open neural tube defect observed in the lumbar spine region with evidence of a myelomeningocele. The defect is seen at the L3-L4 level. with a small sac protruding posteriorly containing cerebrospinal fluid and neural elements. The spinal defect is associated with splaying of the posterior vertebral arches. Extremities. The lower extremities show no evidence of club foot, which is often associated with Chiari-2 malformation. This is the impression. The ultrasound findings are consistent with Chiari-2 malformation, characterized by the lemon sign, banana sign, ventriculomegaly, and a lumbar myelomeningocele. These findings suggest significant neural tube involvement, which is commonly associated with Chiari-2 malformation and may lead to neurological deficits. Follow-up ultrasound in 2 to 3 weeks is recommended to monitor fetal growth, amniotic fluid levels, and any progression of the malformation. Now we have obstetric ultrasound reports focusing on fetal spine. The first case is myelomeningocele. These are the findings of the head and brain. Biometry consistent with gestational age. Ventricles are within normal limits, but mild ventriculomegaly is noted, lateral ventricles measuring 11 millimeters. Posterior fossa assessment reveals obliteration of the cisterna magna with downward herniation of the cerebellar tonsils. Chiari-2 malformation noted. Spine. A neural tube defect is noted in the lumbar region, consistent with myelomeningocele. There is an open defect measuring approximately 15 millimeters with protrusion of the spinal cord elements into a sac-like structure. The defect extends from L2 to L5 vertebrae. Limbs. Lower limb movements are reduced, suggesting possible motor impairment secondary to the neural tube defect. Club foot is visualized in both lower limbs. This is the impression. Fetal myelomeningocele, lumbar region L2 to L5. Associated Chiari-2 malformation with mild ventriculomegaly. Bilateral club foot likely secondary to neural tube defect. Close follow-up with serial ultrasounds to monitor fetal growth and development are recommended. Here is a case of diastematomyelia. These are the findings of the spine. A split spinal cord is identified consistent with diastematomyelia. The splitting is observed at the thoracolumbar junction, T12 to L2 levels. A bony spur is visualized within the vertebral canal, separating the two hemichords. Both hemichords appear symmetric and no other gross malformations are observed. No associated myelomeningocele or open neural tube defect seen. Limbs. Bilateral leg movements visualized but mildly reduced compared to upper limbs. No evidence of club foot, although mild limb contractures are noted, possibly secondary to the spinal anomaly. Impression. Diastematomyelia identified at the thoracolumbar region T12 to L2, characterized by the splitting of the spinal cord and a bony spur separating the hemichords. Mild reduction in lower limb movement with no overt limb deformities. No associated neural tube defects, Chiari malformation, or hydrocephalus observed. Serial ultrasounds to monitor fetal development, particularly motor function of the lower limbs, are recommended. This is a case of caudal regression syndrome, gestational age 21 weeks 2 days, reason for ultrasound, detailed anomaly scan due to maternal diabetes. Amniotic fluid. mildly reduced amniotic fluid volume, AFI is 5 centimeters. Spine. The lower spine shows abnormal development with partial or complete agenesis of the sacrum, consistent with caudal regression syndrome. No evidence of associated open neural tube defects or visible myelomeningocele. The thoracic and upper lumbar spine are normal in appearance. The lower lumbar and sacral segments are truncated and hypoplastic. Lower limbs. Significant abnormalities noted in the lower extremities. The femurs are shorter than expected for gestational age. Femur length below 5th percentile. Bilateral limb contractures are present, and both feet show a fixed club foot deformity. Reduced fetal movement in the lower limbs, possibly secondary to the spinal anomaly. Abdomen. The fetal kidneys are visualized and appear small. Bilateral renal hypoplasia. The bladder is visualized and its size is within normal limits. The stomach is normal in appearance. This is the impression, caudal regression syndrome, evidenced by sacral agenesis, short lower limbs, and limb contractures, associated bilateral clubfoot deformity and renal hypoplasia. Mildly reduced amniotic fluid, oligohydramnios, likely related to the renal anomaly. This is a report regarding sacrococcygeal teratoma. These are the findings. Spine. A large heterogeneous mass is visualized at the fetal sacrococcygeal region, measuring approximately 7.5 into 6 into 5.5 centimeters. The mass is predominantly external, with a small portion extending into the pelvic cavity. It appears to be well circumscribed and solid, with multiple cystic areas. Vascularity is noted within the mass on Doppler ultrasound, with a prominent blood supply, consistent with a sacrococcygeal teratoma. The mass is classified as an Altman type 2 sacrococcygeal teratoma, which is predominantly external with an internal component. This is the impression, a large sacrococcygeal teratoma, classified as Altman type 2, predominantly external with a small internal component. No evidence of hydrops fetalis or heart failure at this time. Vascularity noted within the mass, indicating a potential risk for high output cardiac failure as the pregnancy progresses. Recommendations: serial ultrasounds for close monitoring of fetal growth, tumor size, and potential development of complications such as hydrops or polyhydramnios. Here is a case of scoliosis. These are the findings. Spine. Abnormal curvature of the spine is observed, consistent with fetal scoliosis. The curvature is most pronounced in the thoracolumbar region, forming a C-shaped deformity. The vertebrae appear intact without evidence of segmentation anomalies or hemivertebrae. No open neural tube defect or evidence of a tethered cord. The rest of the spinal column, including the cervical and sacral regions, appears normal. This is the impression, fetal scoliosis with a C-shaped curvature of the thoracolumbar spine. No associated neural tube defects or vertebral segmentation anomalies identified at this time. Normal growth and development of the fetal limbs and internal organs. This is a report for kyphosis. These are the spine findings. Abnormal forward curvature of the spine noted in the thoracic region, consistent with kyphosis. The kyphotic deformity is most pronounced at T6 to T10 vertebrae, forming an exaggerated forward bend. The vertebrae are well formed with no evidence of vertebral segmentation anomalies or hemivertebrae, no evidence of open neural tube defects or spinal dysraphism. Lumbar and cervical spine appear normal with no additional curvatures. This is the impression. Fetal kyphosis with significant curvature in the thoracic spine, T6 to T10, no associated vertebral segmentation anomalies, spinal defects, or other structural abnormalities noted at this time. These ultrasound reports will focus on fetal chest pathologies. The first case is atrioventricular septal defect. This is the patient information. Gestational age 24 weeks plus 5 days. Clinical indication: routine second trimester anatomy scan with a focus on detailed cardiac evaluation due to a family history of congenital heart disease. These are the findings of the heart. Heart position and size. The heart is in the normal position within the left thoracic cavity with an overall size appropriate for gestational age. Four-chamber view. A significant abnormality is noted in the four-chamber view. There is a large atrioventricular septal defect characterized by a common atrioventricular junction and a single atrioventricular valve bridging both the left and right ventricles. Outflow tracts. The right and left ventricular outflow tracts are visualized and appear to arise normally. However, mild enlargement of the right ventricle is noted, likely secondary to increased preload. Color Doppler confirms the presence of left to right shunting at both the atrial and ventricular levels. There is no evidence of additional intracardiac shunting or significant obstruction. Fetal heart rate is 142 beats per minute, regular rhythm. Color Doppler confirms the presence of left to right shunting at both the atrial and ventricular levels. There is no evidence of additional intracardiac shunting or significant obstruction. This is the impression. AVSG, a complete atrioventricular septal defect, is identified. The defect is hemodynamically significant and will require specialized cardiac evaluation and management. No other congenital anomalies were identified during this examination. This is a report for Epstein's anomaly. These are the findings of the heart. Four-chamber view. The heart is in the left chest with normal axis. However, there is significant apical displacement of the tricuspid valve into the right ventricle. Right atrium enlarged, consistent with atrialization of the right ventricle. Tricuspid valve malformed with limited movement. Regurgitation is noted on color Doppler. Right ventricle severely hypoplastic with atrialized portion seen. Left ventricle appears structurally normal with appropriate size. Tricuspid regurgitation moderate to severe with high velocity flow noted on Doppler. Flow across the foramen ovale, left to right shunting noted. Pulmonary valve, evidence of stenosis with decreased forward flow. This is the impression. Findings are consistent with Epstein's anomaly, characterized by apical displacement of the tricuspid valve, atrialization of the right ventricle, and associated tricuspid regurgitation. Pulmonary stenosis is also noted. Close follow-up with serial ultrasounds to monitor the progression of cardiac anomalies is recommended. Now we have a report regarding hypoplastic left heart syndrome. These are the heart findings. Four-chamber view, significant asymmetry of the ventricles is noted. The left ventricle is severely hypoplastic, while the right ventricle is dilated and dominant. Left atrium small with reduced inflow from the hypoplastic left ventricle. Right ventricle enlarged with hypertrophy noted. The tricuspid valve appears normal with normal inflow and outflow observed. Pulmonary artery normal in size and origin. There is antegrade flow across the pulmonary valve. Aorta. The ascending aorta is extremely small, consistent with hypoplastic left heart syndrome. The aortic arch appears hypoplastic. This is the impression. Findings are consistent with hypoplastic left heart syndrome, characterized by severe hypoplasia of the left ventricle and a hypoplastic ascending aorta. The right ventricle is dominant. Urgent referral to a fetal cardiologist for detailed echocardiography and counseling is recommended. This is a report about transposition of the great arteries. These are the findings of the heart. Four-chamber view, symmetric and well-formed atria and ventricles. No obvious defects within the chambers themselves. Aorta arises from the right ventricle and runs parallel to the pulmonary artery. The aortic arch is visualized and appears to be of normal caliber with normal branching. Pulmonary artery arises from the left ventricle running parallel to the aorta. The pulmonary artery is normal in size with normal branching into the left and right pulmonary arteries. This is the impression. The ultrasound findings are consistent with transposition of the great arteries characterized by the aorta arising from the right ventricle and the pulmonary artery arising from the left ventricle, with both great arteries arranged in a parallel configuration. No other cardiac anomalies are detected at this time. This is a report about tetralogy of Fallot. These are the heart findings. Four-chamber view. The four chambers are visualized with a noticeable discrepancy in ventricular size. The right ventricle appears slightly larger than the left. Ventricles. The right ventricle is hypertrophic, consistent with increased workload. The left ventricle is slightly smaller but appears structurally normal. Ventricular septum. A large ventricular septal defect is visualized in the perimembranous region, measuring approximately 4 mm in diameter. Pulmonary outflow tract. The pulmonary valve is noted to be stenotic, with a small and hypoplastic main pulmonary artery. The aorta is overriding the ventricular septum, arising from both the left and right ventricles, confirming the diagnosis of tetralogy of Fallot. Ductal arch. The ductus arteriosus appears patent, with normal flow observed. Ventricular septal defect. Bidirectional flow is noted across the VSD, with predominance of left to right shunting. Pulmonary flow. Increased flow velocity noted across the pulmonary valve, consistent with stenosis. The pulmonary artery appears small, with reduced forward flow. Aortic flow. Normal forward flow observed, with the aorta overriding the VSD. This is the impression. The ultrasound findings are consistent with tetralogy of Fallot, characterized by a large ventricular septal defect, overriding aorta, right ventricular hypertrophy, pulmonary stenosis with a hypoplastic pulmonary artery. Recommendations. referral to a fetal cardiologist for detailed fetal echocardiography and further evaluation. This is a report for truncus arteriosus, heart findings. A single large arterial trunk is visualized, arising from the heart and overriding the ventricular septum. This single vessel gives rise to the pulmonary arteries, aortic arch, and coronary arteries. The aortic arch is visualized arising from the truncus, with normal branching into the head and neck vessels. Both pulmonary arteries arise from the truncus arteriosus, with normal branching into the left and right pulmonary arteries. Ductal arch. The ductus arteriosus is not distinctly visualized, likely absent due to the presence of a common arterial trunk. This is the impression. The ultrasound findings are consistent with truncus arteriosus, characterized by a single arterial trunk arising from the ventricles and overriding a large ventricular septal defect. This trunk supplies both the systemic and pulmonary circulations, with no evidence of a separate ductus arteriosus. Here is a report regarding ectopia cordis. These are the findings of the chest. The heart is noted to be partially or completely extrathoracic, consistent with ectopia cordis. The heart appears to be located outside the thoracic cavity, with no protective sternum covering the heart. Cardiac anatomy. 4 chambers are visualized, with the heart appearing structurally normal, although displaced outside the thorax. The great vessels are also visualized, and they appear to be in their expected locations relative to the heart. The lungs are hypoplastic, likely due to the limited intrathoracic space caused by the ectopic heart. Cardiac function. Normal heart rate and rhythm are observed. Contractility appears within normal limits despite the ectopic location. Blood flow. Normal Doppler flow patterns are observed within the major cardiac vessels, including the aorta and pulmonary artery. There is no evidence of significant valvular stenosis or regurgitation. Abdomen, stomach, bladder, kidneys, and bowel are visualized and appear normal. The abdominal wall appears intact, with no evidence of other associated anomalies such as omphalocele or gastroschisis. The hands and feet are normal. This is the impression. The ultrasound findings are consistent with ectopia cordis. The heart appears structurally normal, but its extrathoracic position is associated with a high risk of other anomalies and complications. Urgent referral to a fetal cardiologist and pediatric surgeon for further evaluation and counseling is recommended. Here is a report regarding echogenic intracardiac focus. Intracardiac findings. A single echogenic intracardiac focus is noted in the right ventricle. The focus measures approximately 2 mm in diameter. No other intracardiac or extracardiac anomalies are identified. This is the impression. A single echogenic cardiac focus is present in the right ventricle. This finding does not necessitate any further evaluation or follow-up unless additional risk factors or anomalies are present. No other abnormalities were detected during the examination. The findings are consistent with a healthy fetus at 20 weeks of gestation. This is a report of rhabdomyoma. Heart findings. Heart rate 145 beats per minute, regular rhythm. 4-chamber view. A well-defined hyperechoic mass measuring 6 mm is identified in the left ventricle of the heart. The mass is consistent with a rhabdomyoma, a benign cardiac tumor. No obstruction of outflow tract is observed. The remainder of the cardiac anatomy is unremarkable. This is the impression. A single cardiac rhabdomyoma is noted in the left ventricle. A detailed fetal anatomy survey was performed and no other anomalies were identified. Further evaluation, including possible referral to a pediatric cardiologist and consideration for genetic counseling, is recommended. This is a case of congenital diaphragmatic hernia. These are the chest findings. Heart rate 155 beats per minute, regular rhythm. Four-chamber view of the heart is normal. Intrathoracic contents, the stomach, part of the bowel, and a portion of the liver are visualized within the left thoracic cavity, displacing the heart to the right. The lungs appear hypoplastic, with the left lung being particularly small. Abdomen. The abdominal circumference is reduced due to the herniation of abdominal organs into the thoracic cavity. The remainder of the abdominal organs are visualized and appear structurally normal. This is the impression. Left-sided congenital diaphragmatic hernia. A significant portion of the abdominal contents, including the stomach, bowel, and liver, is herniated into the left thoracic cavity, causing mediastinal shift and lung hypoplasia. Apart from the diaphragmatic hernia, the remaining fetal structures appear to be developing normally. Recommendation: consideration for fetal MRI to better assess lung volumes and confirm the extent of the hernia. Continued close monitoring of fetal growth and development with serial ultrasounds. This is a report regarding congenital pulmonary airway malformation type 1 macrocystic. These are the chest findings. Heart rate is normal. The heart is slightly displaced to the left due to the presence of a large cystic lesion in the right thoracic cavity. Right lung. A large, well-circumscribed cystic mass is identified occupying the right lung. The mass contains a large single cyst measuring approximately 20 mm in diameter, consistent with type 1 CPAM. The mass is causing a shift of the mediastinum to the left side, with mild compression of the heart and left lung. Left lung appears hypoplastic, secondary to the mass effect from the CPAM. Diaphragm is normal. This is the impression. A large single cystic lesion is present in the right lung, consistent with type 1 CPAM. The mass is causing a mediastinal shift and mild compression of the left lung. The large cystic mass is causing a displacement of the heart and left lung, with potential implications for fetal lung development and function. Fetal MRI and regular follow-up ultrasounds are recommended. This is a report of CPAM type 2. Thorax findings. Left lung. Multiple small to medium-sized cystic lesions are identified throughout the left lung parenchyma, consistent with type 2 CPAM. The cysts range in size from 3 mm to 10 mm. The mass effect from these cysts is causing a significant mediastinal shift to the right, compressing the right lung and displacing the heart. Right lung appears compressed due to the mediastinal shift but maintains normal echo texture. There is a concern for hypoplasia due to the compression. Diaphragm is intact and normally positioned. Impression Type 2 Polycystic congenital pulmonary airway malformation of the left lung with mediastinal shift. The mediastinal shift and compression of the right lung may lead to pulmonary hypoplasia, which can significantly impact neonatal respiratory function. Recommendations: immediate referral to a maternal fetal medicine specialist for detailed evaluation and counseling, consideration for fetal MRI to better assess the extent of lung involvement, evaluate lung volumes, and further characterize the mediastinal shift. Now we have a report of type 3 CPAM. These are the chest findings. Heart rate is normal. 4-chamber view. The heart is visualized but is displaced towards the right side of the thorax due to a large mass in the left lung. The left lung is markedly hyperechoic with a homogeneously solid appearance, consistent with type 3 CPAM. The mass effect from this lesion is causing a significant mediastinal shift towards the right, displacing the heart and compressing the right lung. The size of the left lung is significantly reduced, indicating severe pulmonary hypoplasia. Right lung appears compressed due to the mediastinal shift, though it maintains normal echo texture. There is concern for hypoplasia secondary to the mass effect. The diaphragm is intact and normal. This is the impression. The left lung is hyperechoic and solid in appearance, consistent with type 3 CPAM. This lesion is causing a significant mediastinal shift towards the right, resulting in displacement of the heart and compression of the right lung. The left lung is markedly hypoplastic, and there is concern for compromised development of the right lung due to the mediastinal shift. Immediate referral to a maternal fetal medicine specialist and fetal MRI are advised. Now we have a case of bronchopulmonary sequestration. These are the chest findings. Left lung, a well-defined hyperechoic mass is identified in the lower left lung, measuring approximately 3.5 centimeters in diameter. This mass is consistent with bronchopulmonary sequestration. The mass has its own blood supply, with an aberrant artery arising from the aorta, confirmed by color Doppler imaging. Right lung appears normal in size and echo texture, with no evidence of compression or involvement in the sequestration. Diaphragm is normal. This is the impression. A well-circumscribed hyperechoic mass in the left lower lung is consistent with bronchopulmonary sequestration. No other anomalies are detected in the current examination. Fetal growth is appropriate for gestational age. MRI and serial ultrasounds are recommended. This is a report of bronchogenic cyst. Chest findings. A large cystic mass consistent with a bronchogenic cyst is identified in the left lung of the fetus. The cyst measures approximately 2.5 centimeters in its greatest dimension. The cyst is predominantly fluid-filled with no solid components visualized. The mass is exerting pressure on the surrounding lung tissue, leading to a significant mediastinal shift towards the right. The heart is displaced from its normal central position to the right side of the thorax. No signs of hydrops fetalis are observed. The mediastinal shift is causing a deviation of the fetal trachea and major vessels to the right. The right lung appears slightly compressed but demonstrates normal echogenicity. The left lung is underdeveloped compared to the right, likely due to mass effect. Impression: a large bronchogenic cyst in the left lung with significant mediastinal shift. The findings suggest a potential for fetal compromise due to the mass effect and compression of thoracic structures. Further evaluation by a pediatric surgeon and/or neonatal specialist is recommended. Continuous monitoring through follow-up ultrasounds is advised. This is a report for congenital high airway obstruction syndrome or CHAOS. Chest findings: the fetal thorax is enlarged with a significant increase in lung echogenicity bilaterally. The lungs appear hyperexpanded, occupying a larger than normal portion of the thoracic cavity. There is an absence of normal lung compression, leading to an outward bowing of the ribs. The diaphragm is flattened and appears inferiorly displaced. The heart is centrally located, with no significant mediastinal shift noted. No evidence of pericardial effusion or cardiac compression. The trachea is dilated, with a prominent fluid-filled appearance suggestive of obstruction. Moderate fetal ascites is noted, likely secondary to venous congestion from impaired venous return. No other signs of fetal hydrops, such as skin edema or pleural effusion, are observed. This is the impression. Findings are consistent with CHAOS, characterized by bilateral hyperexpanded lungs, dilated airways, and fetal ascites. Close monitoring of fetal condition with serial ultrasounds to assess for progression of hydrops or other complications is recommended. This is a report of pleural effusion. Findings of the thorax: bilateral pleural effusions are noted, with fluid accumulation seen in both hemithoraces. The fluid is anechoic, consistent with simple pleural effusion. There is compression of the lungs bilaterally, with the lungs appearing slightly hyperechoic. No mediastinal shift is observed, and the heart is in a normal position. The diaphragm is intact and visualized bilaterally. There is no evidence of fetal ascites, skin edema, or scalp edema, suggesting that hydrops fetalis is not present at this time. Impression: bilateral pleural effusions are present in the fetal thorax, with no associated signs of hydrops fetalis at this time. Further evaluation, including a detailed fetal echocardiogram and possibly genetic testing, is recommended to determine the underlying cause and guide management. This is a report regarding pericardial effusion. These are the findings. The heart is in a normal position within the thoracic cavity, with no evidence of mediastinal shift. A pericardial effusion is noted, with an anechoic fluid collection surrounding the heart. The heart chambers are visualized, and the heart appears structurally normal, with intact ventricular and atrial walls. The lungs are normally developed and show no evidence of pleural effusion. This is the impression. A pericardial effusion is present, characterized by a fluid collection surrounding the fetal heart. The heart appears structurally normal, and there is no evidence of cardiac tamponade or hydrops fetalis. The etiology of the pericardial effusion is uncertain at this time, and further evaluation is important. Now we will see ultrasound reports focusing on the fetal stomach. This is a normal obstetric ultrasound report. The stomach was normal in this case. Age 28 years. Gravida 2, para 1. Gestational age is 22 weeks plus 3 days. And then you can write the date of examination. These are the findings. This is the fetal biometry. All these values are within normal range. Next is the anatomical survey. Fetal heart. 4-chamber view normal with regular rhythm. No abnormalities detected. Fetal spine. Normal alignment and intact throughout its length. Fetal brain. No intracranial abnormalities noted. Cavum, septum pellucidum and lateral ventricles are normal. Fetal face. Profile and orbits appear normal. Fetal stomach. Visualized in the left upper quadrant of the abdomen, fluid filled. Both kidneys are visualized, normal in size and echo texture. Fetal bladder, present, filled and normal in appearance. Amniotic fluid index, 14 centimeters. It is normal in range. Placenta, anterior, grade 1 maturity, clear of the internal os. Umbilical cord, 3 vessels, 2 arteries and 1 vein, confirmed. Cervical length is 3.5 cm. The cervix is closed. This is the impression. The overall fetal anatomy and biometry are consistent with the reported gestational age. Routine follow-up ultrasound as per standard obstetric care is recommended. Now we will look at pathologies. All the findings are not included because it will become repetitive. Only the stomach findings are written. This is a case of gastric pseudomass. These are the findings of the stomach, visualized in the left upper quadrant of the abdomen. A soft tissue echogenic area within the stomach lumen was noted with no shadowing. The echogenic area is consistent with the gastric pseudomass, likely due to swallowed debris or vernix. The pseudomass is mobile and does not appear to cause obstruction. The overall stomach size, position, and function remain normal, with intermittent filling and emptying observed. The fetal stomach demonstrates a gastric pseudomass, likely representing swallowed debris or vernix. This is a benign finding with no associated structural abnormalities or obstruction. Continued routine prenatal care is advised, with follow-up ultrasound if clinically indicated. The next case is esophageal atresia. These are the findings of the stomach. The fetal stomach is not visualized despite multiple attempts during the scan. Persistent non-visualization of the stomach raises concerns for esophageal atresia. No gastric contents are seen. The absence of stomach visualization is consistent with a potential complete esophageal atresia. Amniotic fluid index is 28 centimeters. It is increased, which is consistent with polyhydramnios. Here is the impression. The ultrasound findings of non-visualization of the fetal stomach, along with polyhydramnios, are highly suggestive of esophageal atresia. The findings warrant further evaluation and consultation with a maternal fetal medicine specialist. Correlation with fetal echocardiography and genetic counseling is recommended due to the association with other anomalies. This is another case of esophageal atresia in which a small stomach was visualized along with polyhydramnios. In this case, the AFI was 28 centimeters, indicating polyhydramnios. Esophagus. The proximal esophagus appears dilated with an absence of a continuous lumen to the stomach. This finding is suggestive of esophageal atresia. The fetal stomach is visualized but appears small and less filled than expected for the gestational age. The small stomach may reflect an associated tracheoesophageal fistula. Additional findings. The presence of polyhydramnios, small fetal stomach, and discontinuity of the esophagus are highly suggestive of esophageal atresia. This is the impression: esophageal atresia. The ultrasound findings are consistent with esophageal atresia, evidenced by the dilated proximal esophagus, small stomach, and polyhydramnios. A tracheoesophageal fistula may also be present, but its confirmation requires postnatal evaluation. Polyhydramnios. Significant polyhydramnios is observed, likely secondary to the impaired swallowing mechanism due to esophageal atresia. Detailed follow-up ultrasound to assess fetal growth and amniotic fluid levels is recommended. Now we have a report of duodenal atresia. These are the findings. The fetal stomach appears distended and is notably larger than expected for gestational age. Duodenum. A second fluid-filled structure is seen adjacent to the stomach, suggestive of a double bubble sign, characteristic of duodenal atresia. Small bowel. No significant bowel loops visualized distal to the duodenum. AFI is also increased, 26 centimeters, indicating polyhydramnios. Here is the impression of the report. Ultrasound findings are consistent with duodenal atresia, as indicated by the double bubble sign and polyhydramnios. The condition will likely require surgical correction postnatally. Polyhydramnios is observed, likely secondary to duodenal atresia, which impairs normal swallowing and absorption of amniotic fluid. Regular follow-up ultrasound to monitor amniotic fluid levels and fetal growth is recommended, and neonatal surgical consultation should be considered. This is a report of congenital diaphragmatic hernia. Findings: fetal anatomy, thorax. A left-sided congenital diaphragmatic hernia is identified. The stomach and portions of the bowel are visualized within the left thoracic cavity, displacing the heart to the right. The lung-to-head ratio (LHR) is calculated at 1, suggesting a moderate degree of pulmonary hypoplasia. The heart is structurally normal but displaced to the right, dextro position, due to the herniated abdominal organs. Four-chamber view shows normal cardiac anatomy with no evidence of congenital heart defects. Abdomen. The liver is in its normal intra-abdominal position with no evidence of herniation. The kidneys and bladder are normal. Spine and extremities. Normal with no detected abnormalities. This is the impression. The ultrasound reveals a single live intrauterine fetus at 22 weeks plus 5 days gestation with a left-sided congenital diaphragmatic hernia. The stomach and bowel are herniated into the thoracic cavity, causing mediastinal shift and rightward displacement of the heart. No other structural anomalies are identified, but the condition is associated with a significant risk of pulmonary hypoplasia and other complications. Recommendations: fetal MRI for detailed assessment of lung volumes and the extent of herniation. Regular follow-up ultrasounds to monitor fetal growth, amniotic fluid levels, and lung development. These ultrasound reports focus on fetal bowel pathologies. Our first case is jejunal atresia. This is the report. Gestational age is 26 weeks plus 3 days. Clinical information: previous ultrasound showed mild polyhydramnios. No other significant medical history. These are the findings: fetal biometry. The BPD head circumference and femur length correspond to 26 weeks, but abdominal circumference corresponds to 24 weeks. It is approximately 2 weeks behind. The gestational age is 26 weeks. These are the abdomen findings. Stomach. Normal visualization of the stomach bubble on the left side. No abnormalities noted. Intestines. Distension of proximal jejunal loops noted, measuring up to 20 millimeters in diameter. Multiple dilated bowel loops were visualized proximal to the site of suspected obstruction. No free fluid in the abdomen. No visible meconium peritonitis or calcifications. The site of obstruction in the mid-abdomen is suggestive of jejunal atresia. No evidence of duodenal atresia. Double bubble sign is absent. It is an indicator of duodenal atresia. All the other normal findings are not written due to repetition. Only the abdominal findings and abnormal findings are written. Everything else besides the abnormalities was normal. Amniotic fluid. The AFI is 27 centimeters, which indicates polyhydramnios. Here is the impression. Findings consistent with jejunal atresia suggested by the presence of dilated loops of bowel in the jejunal region. Polyhydramnios, likely secondary to gastrointestinal obstruction. Normal growth parameters, though abdominal circumference is slightly smaller for gestational age. Recommendations include fetal MRI and follow-up ultrasound in 2 to 4 weeks. This is a report regarding dilated bowel loops. These are the findings. Amniotic fluid index is 25 centimeters, which indicates borderline polyhydramnios. These are the findings in the abdomen, bowel. Multiple dilated bowel loops visualized in the fetal abdomen, predominantly in the small bowel. The largest loop measures approximately 15 millimeters in diameter. No evidence of double bubble sign. No evidence of free intra-abdominal fluid or ascites. Bowel wall thickness appears normal with no signs of echogenic material suggestive of meconium peritonitis. Stomach. Normal gastric bubble visualized in the left upper quadrant. Liver, spleen, gallbladder and kidneys were all normal. This is the impression. Multiple dilated bowel loops suggestive of a potential obstruction in the fetal gastrointestinal tract, likely mid or distal small bowel. Polyhydramnios, likely secondary to gastrointestinal abnormality. Recommendations include fetal MRI and follow-up in 2 to 3 weeks. Now we have a case of meconium ileus. These are the findings. Amniotic fluid index is 28 centimeters, which indicates polyhydramnios. Multiple dilated bowel loops noted, particularly in the distal small intestine. The largest bowel loop measures approximately 18 millimeters in diameter. Increased bowel echogenicity visualized, consistent with inspissated meconium. This finding suggests meconium ileus. No double bubble sign indicative of duodenal atresia. No visible free fluid in the abdomen or signs of ascites. No intra-abdominal calcifications noted, which would suggest meconium peritonitis. Stomach, normal appearance and size with the stomach bubble clearly visible in the left upper quadrant. This is the impression, findings suggestive of meconium ileus, evidenced by dilated echogenic bowel loops and possible obstruction of the distal bowel. Polyhydramnios, likely secondary to the gastrointestinal obstruction. Recommendations include fetal MRI and follow-up ultrasound in 2 to 3 weeks. This is a report of meconium peritonitis. These are the findings. Amniotic fluid index is increased. It is 30 centimeters, which indicates polyhydramnios. Bowel, several dilated bowel loops noted, with the largest loop measuring 20 millimeters. Increased echogenicity of bowel consistent with bowel thickening. Evidence of intra-abdominal calcifications suggestive of meconium peritonitis. No significant free intra-abdominal fluid or ascites. Bowel perforation is suspected based on calcifications. This is the impression. Findings consistent with meconium peritonitis, evidenced by intra-abdominal calcifications, bowel dilatation and echogenicity, likely bowel perforation with associated peritonitis. Polyhydramnios, likely secondary to gastrointestinal obstruction or inflammation. Recommendations include serial ultrasounds and fetal MRI. This is a case of omphalocele. These are the findings of the abdomen, abdominal wall, evidence of a midline defect at the base of the umbilical cord, measuring approximately 25 millimeters. A portion of the liver and small bowel are herniated into the sac, consistent with an omphalocele. The omphalocele is enclosed by a membrane. No signs of rupture or evisceration of the abdominal contents. The umbilical cord is seen inserting at the apex of the omphalocele sac. Liver is partially herniated into the omphalocele sac. Gallbladder, spleen and kidneys are visualized in their normal positions and have normal echo texture. This is the impression. Omphalocele containing both liver and bowel, enclosed by a membrane. No signs of rupture or associated anomalies visible at this time. Normal amniotic fluid levels. Growth parameters are appropriate for gestational age. Recommendations: referral to maternal fetal medicine specialist for further evaluation and counseling. Follow-up ultrasound to monitor fetal growth and assess any potential associated anomalies. This is a report of gastroscosis. These are the abdominal findings. A small right-sided paraumbilical defect is observed, with free-floating loops of bowel seen protruding outside the abdominal cavity, consistent with gastroscosis. No covering membrane is present. The bowel appears mildly dilated, but with normal echogenicity, indicating no signs of severe bowel wall thickening or inflammation. No involvement of the liver or other abdominal organs in the defect. Liver, gallbladder, kidneys and spleen are normal. This is the impression, gastroscosis, characterized by a right-sided paraumbilical abdominal wall defect with free-floating loops of bowel, no liver involvement or evidence of associated anomalies at this time. Normal amniotic fluid levels. Fetal growth is within normal limits for gestational age. Now we will look at obstetric ultrasound reports regarding fetal bladder and kidney pathologies. Our first case is pelvic kidney. These are the findings regarding kidneys and bladder. This is not a full obstetric ultrasound report. We are only focusing on the findings regarding kidneys and bladder. Right kidney, normal in size and echo texture, located in the right renal fossa. Left kidney, not visualized in the left renal fossa. Pelvic kidney, a well-circumscribed homogeneous structure measuring 22 into 15 millimeters, is visualized on the left side of the fetal pelvis, suggestive of a left pelvic kidney. The kidney has normal architecture and the renal pelvis is mildly dilated. AP diameter is 4 millimeters. Bladder, normal filling noted, no evidence of bladder outlet obstruction. This is the impression. Left pelvic kidney, ectopic kidney. The left kidney is ectopically located in the pelvis. It appears structurally normal with mild pelviectasis. The right kidney is visualized in the normal position and is of normal size and appearance. There is no evidence of obstruction or other significant renal anomalies. Follow-up: recommend postnatal ultrasound to assess the function and position of the left kidney. Continue routine obstetric care. This is a report regarding crossed-fused ectopia. These are the findings. Right kidney, not visualized in the right renal fossa. Left kidney, enlarged and located in the left lumbar region, measuring 45 into 30 millimeters. The kidney shows fusion with a second, smaller renal mass, suggestive of the right kidney, which is located on the left side, medial to the normal left kidney. Cross-fused renal ectopia. Both kidneys are fused and located on the left side. The right kidney has crossed over and is fused inferiorly to the left kidney, forming a lobulated structure. No significant pelvic LCL dilatation is noted, and the renal pelvises are normal. Bladder is normal in appearance. Here is the impression. Cross-fused renal ectopia. The right kidney is ectopically located on the left side, fused to the left kidney. Both kidneys appear to have normal architecture with no significant hydronephrosis or evidence of obstruction. Normal bladder function observed. Postnatal ultrasound recommended for further assessment of renal function and to evaluate for any associated urinary tract anomalies. No immediate obstetric concerns related to the ectopic kidneys. This is a report regarding unilateral renal agenesis. These are the findings. Right kidney, single kidney located in the right renal fossa, normal in size and appearance, measuring 40 into 22 millimeters. No evidence of hydronephrosis or abnormal renal architecture. Left kidney, not visualized in the left renal fossa or elsewhere within the abdomen or pelvis, consistent with left renal agenesis. Bladder is normal in size and echogenicity. This is the impression. Left unilateral renal agenesis. The left kidney is absent, consistent with unilateral renal agenesis. The right kidney is present and appears normal. Bladder function is intact and there is no evidence of obstruction or hydronephrosis. Amniotic fluid levels are within normal limits, suggesting normal renal function. Postnatal renal ultrasound is recommended to confirm the diagnosis and assess the function of the right kidney. Continue routine obstetric care. Now we have a case of bilateral renal agenesis. These are the findings. Amniotic fluid, severe oligohydramnios, amniotic fluid index is less than 2 centimeters. Significantly reduced amniotic fluid volume consistent with absent renal function. Lungs. Hypoplastic appearance of lungs consistent with oligohydramnios-related pulmonary hypoplasia. All limbs are visualized with no deformities. Notably, the extremities show a slightly contracted appearance, possibly secondary to decreased fetal movement due to oligohydramnios. Right kidney not visualized in the right renal fossa or ectopic locations. The left kidney is also not visualized in the left renal fossa or anywhere else. Bladder not visualized during the entire examination, consistent with bilateral renal agenesis and lack of urine production. Here is the impression: bilateral renal agenesis, both kidneys are absent, and no renal tissue is identified in normal or ectopic positions. The absence of a visible bladder and severe oligohydramnios further support the diagnosis. The fetus is at high risk for complications, including pulmonary hypoplasia due to lack of amniotic fluid and renal function. This is a report regarding bilateral UPJ obstruction. These are the findings. Right kidney is enlarged, measuring 48 into 25 millimeters. Marked dilation of the renal pelvis is observed. AP diameter is 11.5 millimeters, consistent with severe hydronephrosis. The renal cortex appears thinned. No obvious urethral dilation is noted, suggestive of right UPJ or uretropelvic junction obstruction. The left kidney is also enlarged, measuring 46 into 24 millimeters, with dilation of the renal pelvis. AP diameter is 8.3 millimeters. This is the diameter of the renal pelvis. No dilation of the ureter is visualized, consistent with left UPJ obstruction. Bladder is visualized with normal filling, no signs of outlet obstruction. Impression: bilateral UPJ obstruction. Both kidneys are significantly dilated due to bilateral UPJ obstruction, resulting in severe hydronephrosis on the right and moderate hydronephrosis on the left. The renal cortices appear thinned, especially on the right, raising concern for potential renal damage. Amniotic fluid level is mildly decreased, which may indicate reduced fetal urine output. Recommend close monitoring with serial ultrasounds to assess the progression of hydronephrosis and amniotic fluid levels. Now we have a case of unilateral UPJ obstruction. These are the findings in the right kidney. Enlarged right kidney with significant hydronephrosis. The AP diameter of the renal pelvis measures 12 millimeters, consistent with severe dilation. No evidence of urethral dilation, suggesting obstruction. The renal cortex is thinned. Left kidney is normal in size and appearance. The bladder is also normal. This is the impression: unilateral UPJ obstruction. The right kidney demonstrates significant hydronephrosis with an AP diameter of 12 millimeters, consistent with UPJ obstruction. The renal cortex appears thinned, raising concerns for potential renal damage. The left kidney appears normal with no evidence of obstruction. Amniotic fluid volume is within normal range, suggesting adequate renal function in the unaffected kidney. Here is a case of moderate hydronephrosis. These are the findings: right kidney enlarged with moderate hydronephrosis, renal pelvis AP diameter measuring 11 millimeters. The renal cortex appears normal and no evidence of urethral dilation is noted. Left kidney moderate hydronephrosis with an AP renal pelvis diameter of 10 mm. The renal cortex appears normal and no dilation of the ureter is observed. This is the impression: bilateral moderate hydronephrosis. Both kidneys show moderate hydronephrosis with no significant thinning of the renal cortex or urethral dilation. Bladder function is normal, and amniotic fluid levels are within the normal range, indicating adequate overall fetal renal function. Recommend serial ultrasound monitoring to assess the progression of hydronephrosis. This is a report regarding severe hydronephrosis. These are the findings. Amniotic fluid index is 5 cm, which is on the lower side of normal range. Mild oligohydramnios present. Right kidney significantly enlarged with severe hydronephrosis. The anteroposterior diameter of the renal pelvis measures 18 mm. The renal cortex is markedly thinned, raising concern for compromised renal function. No obvious dilation of the ureter is noted, suggesting obstruction at the uretropelvic junction. The left kidney is normal. The bladder is visualized but shows reduced filling. This is the impression. The right kidney shows severe hydronephrosis with marked thinning of the renal cortex, suggesting significant renal impairment. The left kidney appears normal. Mild oligohydramnios is present, possibly secondary to reduced fetal urine output from the affected kidney. This is a report regarding multicystic dysplastic kidney. Findings: left kidney, multicystic dysplastic left kidney with multiple non-communicating cysts of varying sizes scattered throughout the renal parenchyma. The kidney is irregularly shaped and no normal parenchyma is seen in the left kidney. Right kidney is normal in size and appearance. The bladder is also normal. This is the impression: multicystic dysplastic kidney, left side. The left kidney demonstrates multiple non-communicating cysts consistent with MCDK. The right kidney is normal. Recommend continued prenatal monitoring with serial ultrasounds to assess fetal growth and amniotic fluid levels. Now we have a case of autosomal recessive polycystic kidneys. These are the findings. Amniotic fluid index is 4 cm, oligohydramnios observed. Liver, increased echogenicity of the liver parenchyma noted, which may suggest congenital hepatic fibrosis associated with ARPKD. No focal liver lesions or biliary ductal dilatation observed. Right kidney, markedly enlarged with increased echogenicity. The kidney measures 65 into 40 mm, significantly larger than expected for gestational age. The renal cortex appears uniformly echogenic without focal areas of thinning. The left kidney has similar findings. The bladder is visualized but appears minimally filled, consistent with decreased urine production. No signs of bladder outlet obstruction. This is the impression: autosomal recessive polycystic kidney disease. Both kidneys are markedly enlarged and diffusely echogenic. The lack of normal corticomedullary differentiation is a characteristic finding of autosomal recessive polycystic kidneys. There is significant oligohydramnios, likely secondary to impaired fetal urine production. These ultrasound reports are related to placental pathologies. The first report is of a normal placenta, gestational age 28 weeks 3 days. Indication is routine obstetric evaluation. These are the findings starting with fetal biometry. All these values are within normal range. Fetal anatomy, head, normal shape, well-defined midline structures, no intracranial abnormalities detected. Spine is intact with normal vertebral alignment, no evidence of spina bifida. Heart, four-chamber view normal, regular rhythm with no apparent structural abnormalities. The abdominal organs and extremities were all normal. The face was normal as well. These are the findings of the placenta. Location anterior, grade 1, which is normal for gestational age. Thickness is 2.8 centimeters, which is also normal. Placental insertion, no evidence of previa. Placenta is well away from the internal os. These are the findings of the umbilical cord. Cord insertion, central. Vessels, 3 vessels visualized, 2 arteries and 1 vein. The cervical length is also normal. The internal os is closed. Fetal position, lie cephalic. Presentation, head down. Fetal movement, active with normal tone. This is the impression. This obstetric ultrasound examination demonstrates a single live intrauterine pregnancy at 28 weeks and 3 days of gestation. The placenta is anterior with no evidence of previa or abruption, and the umbilical cord shows a normal 3-vessel structure. Amniotic fluid volume is within normal limits. The cervix is of adequate length with a closed internal os. Overall, the fetal biometry and anatomy appear consistent with the gestational age, and there are no sonographic findings of concern. This is a report regarding subcenturiate lobe. These are the findings of the placenta. All other normal findings are excluded due to repetition. These are placental findings. Location, posterior, with an anterior subcenturiate lobe. Grade, grade 1. Thickness, 2.9 centimeters. Placental insertion, main placenta is posterior, with a subcenturiate lobe located anteriorly. This is the impression. This obstetric ultrasound examination demonstrates a single, live intrauterine pregnancy at 30 weeks and 4 days of gestation. The placenta is posterior with an anterior subcenturiate lobe identified. The bridging vessels between the posterior main placenta and anterior subcenturiate lobe are intact with no evidence of vasa previa. The umbilical cord shows a normal 3-vessel structure, and the cervix has a normal length with a closed internal os. Fetal biometry and anatomy are consistent with the gestational age, and no other sonographic abnormalities are noted. This is a report of a thick placenta. Gestational age is 34 weeks, 1 day. These are the placental findings. Location anterior, grade 2. Thickness 5.2 centimeters. It is increased thickness. Normal thickness should be less than 4 centimeters approximately. Placental insertion, no evidence of previa. Placenta is well away from the internal os. Echo texture homogeneous with no signs of abruption or placental masses. This is the impression. There is a single live intrauterine pregnancy at 34 weeks and 1 day of gestation. The placenta is anterior with a measured thickness of 5.2 centimeters, which is above the normal range for this gestational age. The increased placental thickness is noted but no evidence of placental abruption, masses, or previa is observed. The umbilical cord has a normal 3-vessel structure, and the cervical length is within normal limits with a closed internal os. Fetal biometry and anatomy are consistent with the gestational age, and there are no other sonographic findings of concern. Further monitoring and follow-up are recommended. This is a case of a thin placenta, gestational age 32 weeks. These are the findings. Location posterior, grade 1, thickness 1.8 centimeters, which is below the normal range. Placental insertion is normal. Echo texture is also normal, it is homogeneous. Here is the impression. The placenta is posterior with a measured thickness of 1.8 centimeters, which is below the normal range, and there was associated polyhydramnios in this case with an AFI of 28 centimeters. Despite the placenta and elevated amniotic fluid, there are no signs of placental abruption, masses, or previa. The umbilical cord is normal as well. The cervical length is normal. Internal os is closed. Fetal biometry and anatomy were also normal. Close monitoring and follow-up are recommended. Now we have a report regarding circumvallate placenta. Clinical indication: routine third trimester ultrasound to assess fetal growth and placental position. The patient has a history of gestational diabetes. No prior history of placenta previa or abruption. Gestational age is 32 weeks plus 4 days. These are the findings. Fetal presentation is cephalic. Estimated fetal weight is 2100 grams. Fetal heart rate is 145 beats per minute with a regular rhythm. Biophysical profile 8 out of 8. It is normal. Amniotic fluid index 14 centimeters. Doppler studies are also normal. Normal umbilical artery SD ratio at 2.3. Placental findings: location, posterior wall of the uterus. Morphology, circumvallate placenta identified. The placenta is noted to have raised, thickened edges with an elevated ring of tissue that encircles the placental margin. Distance from internal os is normal. Placental grade is also normal. Cervical length is normal. No evidence of funneling or cervical incompetence. Uterus and adnexa are also normal. This is the impression. Posterior circumvallate placenta noted with normal placental position and no evidence of previa. Fetal growth and development are within normal limits. Follow-up ultrasound in 2 to 4 weeks to reassess placental condition and fetal growth. This is a case of low-lying placenta. Gestational age 28 weeks plus 3 days. Clinical indication: routine third trimester ultrasound to assess fetal growth and placental position. The patient has a history of previous cesarean section and is being monitored for potential placental issues. These are the findings. Fetal presentation, breech. Estimated fetal weight 1300 grams. Fetal heart rate 150 beats per minute. Regular rhythm. Biophysical profile is normal. AFI is normal. Doppler studies are also normal. Placenta. Location is posterior. Position: low-lying with lower edge extending to approximately 1.8 centimeters from the internal os. Placental grade is normal. There is no evidence of abruption or accreta. This is the impression: posterior low-lying placenta identified, not covering the cervical os but in close proximity, 1.8 centimeters. Fetal growth and development are within normal limits. Follow-up ultrasound in 4 weeks is recommended to reassess placental position. Now we have a report of marginal placenta previa. Gestational age 26 weeks plus 5 days. Clinical indication: follow-up ultrasound due to a history of placenta previa identified in the second trimester. The patient has reported no vaginal bleeding but is being monitored closely given the location of the placenta. Placental findings: location, anterior wall, position, marginal placenta previa with the placental edge reaching the internal cervical os but not covering it completely. Placental grade is normal. Impression: anterior marginal placenta previa identified with the placental edge reaching the internal cervical os. Fetal growth is within normal limits, but the placental position may pose risks as the pregnancy progresses. Follow-up ultrasound in 2 to 3 weeks is recommended to reassess placental position and ensure no progression to complete previa. Now we have a case of partial placenta previa. These are the findings of the placenta. Location: posterior wall of the uterus. Position: partial placenta previa with approximately 30% of the placental tissue covering the internal cervical os. Morphology: the placenta exhibits a smooth surface with no signs of accreta, increta, or percreta. This is the impression: posterior partial placenta previa identified with approximately 30% of the placenta covering the internal cervical os. Fetal growth and development are within normal limits. Now we have a report of complete placenta previa. These are the findings of the placenta. Location: posterior wall of the uterus. Position: complete placenta previa with the placental tissue entirely covering the internal cervical os. Placental grade and morphology are normal. This is the impression: posterior complete placenta previa identified with the placenta entirely covering the internal cervical os. Fetal growth and development are appropriate for gestational age. Recommend a follow-up ultrasound in 2 to 3 weeks to reassess placental position and monitor for any changes or complications. This report is regarding placenta percreta. These are the findings of the placenta. Location: anterior wall of the uterus extending over the lower uterine segment and partially covering the internal cervical os. Position: the placenta shows evidence of abnormal invasion into the uterine wall, consistent with placenta percreta. Placental grade is grade 3, increased echogenicity and multiple lacunae. Morphology: the placenta demonstrates multiple large placental lakes and a disrupted myometrial placental interface. There is clear evidence of placental tissue invading through the entire thickness of the myometrium, extending beyond the uterine serosa, with possible involvement of the bladder. Uterine and adnexal structures. Uterine myometrium significantly disrupted in the area of placental attachment, with loss of the normal hypoechoic zone between the placenta and myometrium. Bladder involvement. The anterior placental tissue appears to invade The posterior bladder wall with abnormal vascularity noted between the placenta and bladder. No free fluid or adnexal masses identified. This is the impression: placenta percreta identified with abnormal placental invasion extending through the myometrium into the uterine serosa and potentially involving the bladder. Fetal growth is appropriate for gestational age, but the placental condition poses significant risks to both the mother and fetus. Recommendations: immediate referral to a tertiary care center for further evaluation and management. This is a report of placental abruption. Gestational age 34 weeks plus 2 days. Clinical indication: emergency ultrasound evaluation due to acute onset of abdominal pain and vaginal bleeding. The patient has a history of hypertension. Here are the findings. Fetal presentation is cephalic. Estimated fetal weight is 2400 grams. Fetal heart rate is 135 beats per minute with irregular rhythm. Biophysical profile 6 out of 8, reduced due to decreased fetal movement. Amniotic fluid index 8 centimeters. Doppler studies: umbilical artery SD ratio elevated at 3.5, indicating potential fetal distress. These are the findings of the placenta. Location: posterior fundal region of the uterus. Position: high fundal placenta with evidence of retroplacental hemorrhage. Placental abruption: a large hypoechoic area measuring approximately 6.5 into 2 centimeters is noted between the placenta and the uterine wall, consistent with a posterior fundal placental abruption. Placental grade is 2. The placenta shows no other abnormalities, but the abruption has caused a partial separation of the placental tissue from the uterine wall. Impression: the ultrasound findings are suggestive of a significant placental abruption involving the posterior fundal placenta. This is associated with partial placental separation, irregular fetal heart rate, and reduced fetal movement, raising concerns for fetal distress. Immediate clinical correlation and appropriate obstetric management are recommended. This is a report of subchorionic hematoma. Gestational age 28 weeks and 3 days. Clinical indication: ultrasound performed due to the patient's complaint of mild spotting and lower abdominal discomfort. The patient has a history of previous subchorionic hematoma in the first trimester. These are the findings of the placenta. Location: posterior wall. Position: the placenta is located posteriorly and high within the uterine cavity, not covering the internal os. A subchorionic hematoma is identified anterior to the placenta, measuring approximately 4 into 2.5 centimeters. The hematoma is located between the chorion and the uterine wall, with no signs of active bleeding. Placental grade is 1. Morphology: the placenta appears otherwise normal, with a homogeneous echo texture and no evidence of placental abruption or previa. This is the impression: posterior placenta with an anterior subchorionic hematoma measuring 4 into 2.5 centimeters. Placenta is otherwise normal, with no signs of abruption or previa. Fetal growth and development are normal. Recommendations: schedule a follow-up ultrasound in 2 to 3 weeks to monitor the size and stability of the subchorionic hematoma and reassess fetal well-being. This is a case of chorioangioma. These are the findings of the placenta. Location is anterior. Position: the placenta is located anteriorly, high within the uterine cavity, and does not cover the internal os. A well-circumscribed hyperechoic mass measuring approximately 3 into 2.5 centimeters is identified within the placenta near its upper margin, consistent with a chorioangioma. The mass does not appear to interfere with umbilical cord blood flow. Placenta is grade 1. Morphology: aside from the chorioangioma, the placenta appears normal with a homogeneous echo texture and no evidence of abruption, previa, or additional issues. Impression: anterior placenta with a chorioangioma measuring 3 into 2.5 centimeters. No evidence of placental insufficiency or fetal compromise at this time. Fetal growth and development are normal. Schedule a follow-up ultrasound in 2 to 3 weeks to monitor the size and impact of the chorioangioma on the placenta and fetus. Now we will look at umbilical cord ultrasound reporting. These reports will focus on umbilical cord pathologies. These will not be complete obstetric ultrasound reports. Only this first report, which is of a normal umbilical cord, will be a complete report. The gestational age is 28 weeks. Indication is routine obstetric ultrasound for evaluation of fetal well-being. These are the findings. Fetal presentation: the fetus is in a cephalic, head-down position. Amniotic fluid: the amniotic fluid volume is within normal limits. The amniotic fluid index, AFI, is approximately 12 centimeters, indicating a normal amount of fluid. These are the findings of the umbilical cord. The umbilical cord has a normal appearance and shows a standard 3-vessel structure consisting of 2 umbilical arteries and 1 umbilical vein. The umbilical cord insertion into the placenta appears normal and centrally located. No evidence of cord abnormalities such as single umbilical artery or cord knots is observed. The placenta is positioned in the posterior fundal region with no evidence of placenta previa or abruption. Placental thickness is within normal range. Fetal heart rate: the heart rate is within normal limits, averaging around 145 beats per minute, with normal variability and no evidence of decelerations. Fetal anatomy appears normal with no obvious structural anomalies noted at this time. Doppler studies of the umbilical artery show normal blood flow patterns with no evidence of abnormal resistance or umbilical artery Doppler abnormalities. Now we move on to pathologies and variants. Now only the findings related to the umbilical cord are shown. The other normal findings are removed to avoid repetition. This report is for single umbilical artery. These are the findings. The umbilical cord is visualized with 2 vessels consisting of 1 umbilical artery and 1 umbilical vein, indicating a single umbilical artery. The umbilical cord insertion into the placenta appears normal and centrally located. No evidence of cord knots or other abnormalities is observed. And this is the impression. A single umbilical artery is present, which is a variant of the normal umbilical cord anatomy. No associated structural abnormalities detected. on this examination. Continued monitoring and follow-up ultrasounds are recommended to ensure normal fetal growth and development. This is a case of eccentric cord insertion. Findings: umbilical cord contains 3 vessels, 2 umbilical arteries and 1 umbilical vein. The umbilical cord insertion into the placenta is noted to be eccentric, located closer to the edge of the placenta rather than the center. There is no evidence of marginal or filamentous cord insertion. No cord abnormalities such as knots or nuchal cord are observed. This is the impression. The umbilical cord demonstrates eccentric insertion, which is within the range of normal variation but requires monitoring for potential impacts on fetal growth. No associated abnormalities detected. Fetal growth and development are currently within normal limits. Now we have a case of marginal cord insertion. Findings: the umbilical cord contains 3 vessels, 2 umbilical arteries and 1 vein. The umbilical cord insertion into the placenta is marginal, located at the edge of the placenta within 2 centimeters of the placental margin. No evidence of filamentous cord insertion or other abnormalities is observed. This is the impression. Marginal cord insertion is present, with the umbilical cord inserting at the edge of the placenta. This may be associated with an increased risk of fetal growth restriction and therefore requires follow-up. Fetal growth and well-being are currently within normal limits. This is a report for filamentous cord insertion. The umbilical cord is noted to have a filamentous insertion, where the cord inserts into the fetal membranes rather than directly into the placental tissue. The vessels then traverse the membrane before reaching the placenta. There is no evidence of vasa previa at this time. The cord contains 3 vessels, 2 umbilical arteries and 1 umbilical vein. And here is the impression. Filamentous cord insertion is present, a condition in which the umbilical cord inserts into the fetal membranes rather than the placenta, increasing the risk for complications such as fetal growth restriction, vasa previa, or preterm delivery. No current evidence of vasa previa or other immediate complications. Fetal growth and development are currently within normal limits. These are the recommendations. Serial ultrasounds are recommended to monitor fetal growth, placental function, and any potential complications associated with filamentous cord insertion. Consider a detailed follow-up scan to reassess the possibility of vasa previa. Discuss findings with the obstetric care provider to determine the appropriate management plan, including potential delivery planning. This report is for Punic presentation. Gestational age 34 weeks plus 2 days. Indication is routine antenatal checkup. These are the findings. The umbilical cord is identified anterior to the presenting part, lying between the fetal head and the internal os. This is consistent with a Punic presentation. Fetal presentation. The fetus is in a cephalic presentation with the head positioned downwards. The BPD, HC, AC, FL, and estimated fetal weight are then written. Amniotic fluid index is within normal range at 14 centimeters. The placenta is located posteriorly, grade 2 maturity, and not low-lying. Doppler studies. Umbilical artery Doppler shows a normal SD ratio of 2.6. Middle cerebral artery Doppler shows normal flow. We will look deeper into the Doppler reports in a separate report collection regarding umbilical artery and MCA. These reports just focus on the umbilical cord. Additional findings: no gross fetal anomalies are noted. The fetal heart rate is 145 beats per minute, regular. The phonic presentation is noted, which may require further monitoring. This is the impression. The ultrasound shows a single live intrauterine fetus in cephalic presentation at 34 weeks plus 2 days gestation. The presence of a phonic presentation should be carefully monitored as it may pose a risk of cord prolapse, particularly during labor. The patient is advised to have follow-up scans to monitor cord position and discuss delivery planning with her obstetrician. Recommendations include ultrasound follow-up in 1 week to reassess cord position and discuss potential risks and delivery options. This is a report for umbilical cord cyst. These are the findings. The umbilical cord has 3 vessels, 2 arteries and 1 vein. A single umbilical cord cyst is identified, measuring 11 millimeters in diameter, located near the fetal abdominal insertion site. The cyst is anechoic, without evidence of septations or solid components, no evidence of vascular compromise or abnormal blood flow through the cord vessels. This is the impression. The ultrasound reveals a single live intrauterine fetus in breech presentation at 20 weeks plus 4 days gestation. A small, isolated umbilical cord cyst is identified near the fetal end of the cord. The finding is likely benign as no other structural anomalies or growth concerns are noted. Isolated umbilical cord cysts are generally associated with a favorable outcome, but follow-up is recommended to monitor the cyst and fetal growth. Repeat ultrasound in 4 weeks to reassess the umbilical cord cyst, and fetal growth is recommended. Here is a report of umbilical vein varix. These are the findings. The umbilical cord contains 3 vessels. A focal dilatation of the intra-abdominal umbilical vein, measuring 9 millimeters in diameter, is noted, consistent with an umbilical vein varix. The varix is located within the fetal abdomen, adjacent to the bladder. No evidence of thrombus within the varix or abnormal flow patterns. This is the impression. The ultrasound confirms the presence of an isolated umbilical vein varix within the fetal abdomen at 32 weeks plus 3 days gestation. The varix appears to be an isolated finding with no evidence of associated fetal anomalies, thrombus, or compromised blood flow. However, due to the potential risk of complications such as thrombosis or fetal hydrops, close monitoring is recommended. This is a report for vasa previa. These are the findings. Umbilical cord and vessels. Vasa previa is identified with fetal vessels coursing over the internal cervical os. Color Doppler confirms that these vessels are part of the umbilical cord and are not protected by Wharton's jelly, placing them at high risk of rupture if labor begins. The umbilical cord has 3 vessels, 2 arteries and 1 vein, and the fetal heart rate is 145 beats per minute, regular. The placenta is anterior and low-lying, with its edge 0.8 centimeters from the internal os. This is the impression. The ultrasound confirms vasa previa in a 29-week plus 2-day gestation fetus with low-lying placenta. The fetal vessels are traversing the internal os, a finding that poses a significant risk of fetal hemorrhage during labor if not managed appropriately. The fetus appears structurally normal and there is no evidence of growth restriction or hydropes. Hospitalization for close monitoring from 32 to 34 weeks gestation is recommended. These reports will focus on fetal intrauterine growth restriction. The first case is mild IUGR. Patient's age is 28 years. Gestational age is 34 weeks plus 2 days. These are the findings. Fetal biometry. The abdominal circumference was smaller. The value is falling within 5th percentile. Estimated fetal weight is 1950 grams. Fetal biometry indicates mild intrauterine growth restriction with estimated fetal weight below the 10th percentile but no significant asymmetry. Placenta, location is posterior, grade 2. Placental appearance is normal with no signs of calcification or abruption. These are the findings of the umbilical artery. SD ratio is 2.9, which is within normal limits. Pulsatility index is also normal. Resistive index is normal as well. And diastolic flow is present and normal. Umbilical artery Doppler is within normal limits, suggesting adequate placental function with no evidence of placental insufficiency. These are the findings of the middle cerebral artery. Pulsatility index is normal. SD ratio is normal. The Doppler findings are normal. There is no evidence of brain sparing effect. Ductus venosus waveform is normal with positive A wave, indicating no signs of cardiac compromise. This is the biophysical profile. Fetal movement is present, it gets 2 points. Fetal tone is present, so 2 points. Fetal breathing movements are also present, 2 points as well. Amniotic fluid volume is normal, so this is also 2 points. Total score is 8 out of 8, which is normal with no signs of fetal distress. This is the impression. Mild intrauterine growth restriction is noted with an estimated fetal weight in the 6th percentile. Despite the low fetal weight, Doppler studies show normal placental function and there is no indication of fetal compromise at this stage. Amniotic fluid index and biophysical profile are both normal, indicating good overall fetal well-being. Recommendations: repeat Doppler studies in 1 to 2 weeks to monitor for any changes in placental function. This is a report of severe IUGR. Patient age is 31. Gestational age is 29 weeks plus 5 days. Indication is suspected intrauterine growth restriction, maternal preeclampsia. These are the findings. Fetal biometry. All the parameters are below 3rd percentile, indicating severe growth restriction. Estimated fetal weight is only 910 grams. Fetal biometry reveals significant intrauterine growth restriction with the estimated fetal weight below the 3rd percentile. Amniotic fluid index is 5.8 centimeters, which indicates borderline oligohydramnios. Umbilical artery SD ratio is 5, it is elevated. Pulsatility index is also elevated. resistive index is elevated as well, and diastolic flow is absent. Elevated resistive indices with absent and diastolic flow indicate significant placental insufficiency, suggesting compromised fetal blood flow and increased risk for fetal hypoxia. Middle cerebral artery pulsatility index is reduced, resistive index is reduced as well. The brain sparing effect is present. SD ratio is also decreased. The decreased pulsatility index and resistive index in the MCA is consistent with a brain sparing effect, indicating that the fetus is redistributing blood flow preferentially to the brain in response to placental insufficiency. Ductus venosus is normal with a positive A wave, indicating no evidence of cardiac compromise at this time. Biophysical profile: fetal movement and fetal tone are present, but fetal breathing movements are absent. Amniotic fluid volume is borderline, so a score of 1 is given. Total score is 5 out of 8, which suggests mild fetal compromise. This is the impression, severe IUGR with fetal weight below the 3rd percentile for gestational age, absent end diastolic flow in the umbilical artery, indicative of significant placental insufficiency and fetal circulatory compromise. Brain sparing effect observed in the MCA, indicating preferential blood flow to the fetal brain as a compensatory mechanism for placental insufficiency. Borderline oligohydramnios. These are the recommendations: urgent consultation with maternal fetal medicine specialist, inpatient admission for close fetal monitoring, including daily Doppler studies and continuous fetal heart rate monitoring. This is another case of severe IUGR. Patient's age is 35. Gestational age is 28 weeks plus 4 days. Indication: suspected IUGR, maternal hypertension. These are the findings, starting with fetal biometry. All the parameters are below the 3rd percentile. Fetal biometry indicates severe IUGR with an estimated fetal weight below the 3rd percentile for gestational age. AFI is 5 centimeters, which indicates borderline oligohydramnios. Umbilical artery, the SD ratio, pulsatility index and resistive index are all elevated, and diastolic flow is reversed. In this case, elevated resistive indices and reversed end diastolic flow indicate severe placental insufficiency and compromised fetal blood flow, consistent with severe IUGR. MCA pulsatility index is normal. There is no evidence of brain sparing effect at present. Ductus venosus, increased pulsatility with A wave present but diminished, indicating early signs of fetal cardiac compromise. Biophysical profile: fetal movement and tone are reduced. Fetal breathing movements are absent. Amniotic fluid volume indicates borderline oligohydramnios. So the total score is 3 out of 8, indicating fetal compromise. This is the impression: severe IUGR with an estimated fetal weight below the 3rd percentile, reversed end diastolic flow in the umbilical artery, indicative of significant placental insufficiency, and increased risk of fetal hypoxia. Early signs of fetal compromise noted on Doppler, elevated ductus venosus pulsatility, biophysical profile score of 3 out of 8, suggesting fetal distress. Recommendations: urgent referral to maternal fetal medicine specialist and hospital admission for close fetal monitoring. These ultrasound reports focus on fetal musculoskeletal pathologies. The first case is polydactyly. These are the findings in the upper limbs of the fetus. Both upper limbs are visualized with normal movement and posture. Right hand, polydactyly noted. There is postaxial polydactyly, additional digit on the ulnar side of the hand. The extra digit appears well formed with normal bone structure. Left hand, normal 5 digits observed, no additional digits or abnormalities. Both arms show normal ossification, joint movement, and no signs of shortening or deformity. All the other findings are normal, so they are not shown to avoid repetition. This fetus only had polydactyly. This is the impression. The fetal biometry and anatomy are overall consistent with normal growth and development for gestational age. Isolated postaxial polydactyly of the right hand is noted. This appears to be an isolated finding with no associated skeletal or systemic abnormalities identified during this ultrasound examination. Our next report is regarding clinodactyly. These are the findings: upper limbs, both arms and hands visualized with normal movement and flexion. Left hand, evidence of clinodactyly affecting the 5th digit, curvature of the little finger toward the ring finger. The digit appears mildly curved with no abnormalities in the surrounding soft tissue or bones. The other 4 fingers of the left hand are normal in appearance and movement. The right hand is normal. This is the impression. The fetal anatomy and growth parameters are consistent with normal development for gestational age. Isolated clinodactyly of the left 5th finger is noted. No other structural abnormalities were detected during this scan. Follow-up growth ultrasound in 4 to 6 weeks is advised to monitor fetal development. This is a case of ectrodactyly. Findings: upper limbs, both arms visualized with normal movement noted. Right hand, ectrodactyly, which is a split hand deformity, is present, with a distinct cleft between the 2nd and 4th digits. The central 3rd digit is missing, while the 1st, 2nd, 4th, and 5th digits are present but show some degree of malformation. There is a wide separation between the remaining digits, giving the characteristic lobster claw appearance. Left hand, similar deformity noted with ectrodactyly of the left hand. The 3rd digit is absent, and the remaining digits show mild malformations. Both forearms demonstrate normal bone length and ossification, with no shortening or other skeletal abnormalities. This is the impression. The ultrasound demonstrates bilateral ectrodactyly involving both hands. This is characterized by the absence of the central 3rd digits and a cleft between the remaining digits, resulting in a split hand appearance. No other structural abnormalities were identified during the scan. In this report, clenched hand was observed. These are the findings: both arms visualized with normal bone length and movement observed. Right hand, the hand is persistently clenched with overlapping fingers noted, particularly the 2nd and 3rd digits over the 4th and 5th digits. This is a concerning finding as persistent clenched hands can be associated with chromosomal anomalies such as trisomy 18, Edwards syndrome. Left hand also appears clenched with similar overlapping fingers. Minimal movement of the fingers was observed during the scan. Both forearms and upper arms demonstrate normal bone structure and no shortening or skeletal deformities. This is the impression. Persistent clenched hands with overlapping fingers were noted bilaterally, which is a soft marker for chromosomal abnormalities, particularly trisomy 18. The rest of the fetal anatomy, including the heart and internal organs, appears normal, with no additional structural abnormalities identified during this scan. This is a report regarding club foot. Findings: lower limbs. Right foot, club foot noted. The right foot appears internally rotated and adducted at the ankle, with the sole of the foot facing inward. No signs of bony abnormalities in the tibia or fibula. Left foot, normal appearance and alignment. No abnormalities detected. Both legs show normal movement and bone lengths are consistent with gestational age. This is the impression. Unilateral club foot, right foot, is identified. The left foot is normal in appearance. Isolated club foot can appear sporadically or it may be associated with other musculoskeletal or genetic conditions. No other structural abnormalities are detected, and the overall fetal growth appears within normal limits. This is a case of rocker bottom foot. These are the findings in the lower limbs. Right foot, rocker bottom foot noted, characterized by a convex sole and prominent calcaneus. The arch of the foot is abnormally rounded, with toes dorsiflexed, giving the classic appearance of a rocker bottom shape. Left foot also exhibits rocker bottom foot deformity with similar features of a convex sole and dorsiflexed toes. Both feet are abnormally positioned but show no additional bone deformities. Both legs are visualized with normal bone lengths and no evidence of shortening or other skeletal abnormalities. This is a report regarding sandal gap toe. Findings: lower limbs. Right foot. A noticeable sandal gap is present between the first and second toes. The separation is more pronounced than usual, but no other abnormalities are detected. The bones of the foot appear normal in length and development. Left foot, similar sandal gap noted between the first and second toes. Foot structure is otherwise normal with no evidence of additional deformities. Both legs show normal bone length and no club foot or other deformities were identified. This is the impression. A sandal gap deformity or increased space between the first and second toes was observed bilaterally. This finding can be an isolated variant, but it may also be associated with chromosomal abnormalities such as trisomy 21, which is Down syndrome. No other structural abnormalities were detected during this scan. Fetal growth and development appear normal for gestational age. Now we have a report of short femur. In this example, gestational age was 24 weeks plus 2 days. These are the findings. Fetal biometry. Only the femur length is shorter. It is corresponding to less than 5th percentile for gestational age. Both femurs are measuring below the 5th percentile for gestational age, suggesting short femur. The femur length discrepancy is isolated and the bones appear normal in shape and echogenicity without signs of fractures or bowing. This is the impression. Bilateral short femurs measuring below the 5th percentile were noted, while the rest of the fetal biometry is consistent with gestational age. Follow-up ultrasound in 4 to 6 weeks to assess fetal growth and any changes in femur length is recommended. This is a report of micromelia. These are the findings. Fetal biometry. The femur length and the humeral length are short. Both the long bones are short, corresponding to less than 3rd percentile. Bilateral micromelia of the upper limbs characterized by marked shortening of the humerus, which is below the 3rd percentile for gestational age. The forearm bones, radius and ulna also appear shortened but are appropriately formed. Hands are visible with normal digit count and no other abnormalities. Micromelia of the lower limbs with shortened femurs bilaterally. The tibia and fibula are also shortened but are appropriately formed. No evidence of clubfoot or other foot deformities is noted. Both upper and lower limb bones appear mildly hypoechoic, raising concerns for skeletal dysplasia. No fractures or bowing of the long bones are observed, but the generalized shortening of the limbs suggests disproportionate fetal growth. This is the impression. Micromelia, which is generalized shortening of all limb segments, is noted, affecting both the upper and lower extremities. This finding raises suspicion for a skeletal dysplasia, such as achondroplasia or thanatophoric dysplasia. No other major structural abnormalities were detected during the scan, but further evaluation is warranted. This is a case of small thorax. These are the findings. Fetal biometry. Only the femur length is short. It is less than 3rd percentile. The estimated fetal weight is below 10th percentile. Thorax. The thoracic cavity is disproportionately small relative to the abdominal circumference and head size, suggesting pulmonary hypoplasia, which is often associated with a small thorax. Normal movement of the diaphragm noted. Limbs. Both upper limbs show shortened humeri and forearms, the radius and ulna, consistent with micromelia. The bones appear mildly hypoplastic but without bowing or fractures. Hands appear normal with appropriate digit formation. Both femurs and lower leg bones are shortened, with the femur length well below the 3rd percentile for gestational age, further supporting the suspicion of skeletal dysplasia. No evidence of foot deformities such as clubfoot. Impression. The fetus presents with a small thorax, which is highly suggestive of a skeletal dysplasia, likely thanatophoric dysplasia or another form of skeletal dysplasia, given the combination of short limbs and a small thoracic cavity. This condition is associated with a high risk of pulmonary hypoplasia. This is a report regarding osteogenesis imperfecta. Gestational age is 24 weeks. Findings: long bones, severe shortening of all long bones including the femur, humerus and tibia. Multiple fractures observed in the bilateral femur, tibia and humerus. Evidence of callus formation in areas of healed fractures suggesting intrauterine fractures. Rib cage, beaded appearance of the ribs suggesting multiple rib fractures. Skull, the calvarium appears abnormally thin with increased compressibility during transducer pressure, suggestive of bone fragility. Spine, no significant curvature or spinal anomalies identified. Normal facial structures observed, no evidence of cleft lip or palate. This is the impression. The ultrasound findings are consistent with osteogenesis imperfecta type 2, a lethal form characterized by severe bone fragility and deformities. The fetus shows significant shortening of the long bones, multiple fractures, and hypomineralization of the skull. The combination of multiple fractures, severe skeletal deformities, and a narrow thoracic cage raises concern for perinatal lethality. This is a report regarding thanatophoric dysplasia, gestational age 21 weeks and 5 days. These are the findings. Fetal biometry. PPD is within normal range. Head circumference is increased, consistent with macrocephaly. Abdominal circumference is normal. Femur length is severely shortened. Humerus length is also severely shortened. Estimated fetal weight is at 5th percentile. Long bones. Marked shortening of all long bones, especially the femur and humerus, consistent with severe skeletal dysplasia. The femurs are bowed, giving a telephone receiver shaped appearance, which is characteristic of thanatophoric dysplasia. No evidence of fractures. Rib cage, narrow and short thoracic cage noted, raising concern for pulmonary hypoplasia. Skull, macrocephaly with a prominent forehead, frontal bossing. No evidence of cranial fractures. Spine, mild platyspondyle, which is flattening of vertebral bodies. No signs of scoliosis or kyphosis. Face, depressed nasal bridge, indicating mid-face hypoplasia. Lungs, echogenicity normal, though underdeveloped secondary to thoracic constriction. Heart, normal four-chamber view, no structural cardiac anomalies observed. Kidneys, bladder, and stomach are normal. This is the impression. Ultrasound findings are consistent with thanatophoric dysplasia, a lethal skeletal dysplasia characterized by severe shortening and bowing of the long bones, especially the femurs, macrocephaly with frontal bossing, narrow and short thoracic cavity, likely resulting in pulmonary hypoplasia, mild platyspondyle, consistent with the diagnosis. This is a report regarding achondrogenesis. These are the findings. Long bones, severe shortening of all long bones, with the femur and humerus particularly affected. Both bones are significantly underdeveloped, consistent with a lethal form of skeletal dysplasia. Rib cage, short and narrow thoracic cage noted. The ribs appear hypoplastic, contributing to a small chest cavity. Spine, notable lack of vertebral ossification, indicating severe skeletal hypomineralization, consistent with the diagnosis of achondrogenesis. Skull, macrocephaly with frontal bossing. Face, depressed nasal bridge, mid-face hypoplasia noted. Thorax, severely hypoplastic thorax, suggesting a high risk for pulmonary hypoplasia. This is the impression. The ultrasound findings are consistent with achondrogenesis, a lethal form of skeletal dysplasia characterized by severe shortening of all long bones with marked underdevelopment and hypomineralization. Significant skeletal hypomineralization, particularly in the spine and ribs, leading to poor ossification. Macrocephaly and frontal bossing, with a disproportionately large head relative to the rest of the body. Narrow thoracic cavity, increasing the risk for pulmonary hypoplasia and resulting respiratory insufficiency after birth. This is a report of achondroplasia, gestational age 25 weeks and 0 days. These are the findings. Fetal biometry, BPD is normal, HC is increased, indicative of macrocephaly. Abdominal circumference is normal. Femur length is shortened, humeral length is also shortened. Estimated fetal weight falls within 20th percentile. Significant shortening of long bones, particularly the femur and humerus, consistent with rhizomelic limb shortening, which is proximal limb shortening. Both femurs and humeri are disproportionately short compared to other fetal measurements. The fetal hands display a trident appearance with separation between the third and fourth fingers, characteristic of achondroplasia. Rib cage, normal-sized thoracic cavity, with no evidence of thoracic hypoplasia. Skull, enlarged skull with macrocephaly, frontal bossing, and a flattened, depressed nasal bridge, all typical findings in achondroplasia. Spine, vertebral bodies appear well ossified, no evidence of scoliosis or platyspondyly. Pelvis, the iliac wings are short and flared, a common finding in achondroplasia. This is the impression. The ultrasound findings are consistent with achondroplasia, the most common form of non-lethal skeletal dysplasia. The following findings support this diagnosis. Rhizomelic shortening of the limbs, particularly the femur and humerus. Macrocephaly with frontal bossing and a depressed nasal bridge. Trident hand appearance with increased space between the third and fourth fingers. This is a report regarding arthrogryposis, gestational age 26 weeks and 4 days. These are the findings. Fetal biometry, all these three parameters are normal. The femur length and humeral length are short, they are below 5th percentile. Estimated fetal weight is at 10th percentile. Limb positioning, persistent abnormal limb positioning observed during the entire scan. Both upper and lower limbs show abnormal flexion and extension, with limited movement throughout the scan. Joints, multiple joint contractures with fixed flexion of the elbows, wrists, knees, and ankles noted. The wrists and ankles appear hyperflexed and the hands are clenched, consistent with arthrogryposis multiplex congenita. Spine, ribcage, and skull are normal. Amniotic fluid index is increased. It is 26 centimeters, indicating polyhydramnios. This is the impression. The ultrasound findings are consistent with arthrogryposis multiplex congenita, characterized by multiple joint contractures in upper and lower limbs, with flexion of elbows, wrists, knees, and ankles. Decreased fetal movement, with limbs held in abnormal positions throughout the scan. Polyhydramnios, possibly due to impaired fetal swallowing, commonly associated with reduced fetal movement. This is a report regarding amniotic band sequence. Findings: right arm, constriction band visualized around the mid-forearm with distal edema. The hand appears underdeveloped with missing digits, likely due to in utero amputation. Left leg, a constriction band around the lower leg associated with deformity of the foot, club foot. There is reduced movement in this limb compared to the contralateral limb. Digits: absent or shortened digits in the right hand. The left foot shows evidence of clubfoot deformity with possible syndactyly. This is the impression. The ultrasound findings are consistent with amniotic band syndrome, characterized by constriction bands around the right forearm and left lower leg, leading to limb deformities and restricted limb growth. Distal limb deformities, including amputation of digits in the right hand and clubfoot in the left leg. No other significant skeletal or organ abnormalities observed at this time. These ultrasound reports are related to fetal twin cases. The first report is regarding normal fetal twins. In this example, gestational age is 26 weeks and 3 days. These are the findings. Fetal presentation. Both twin A and twin B are in breech presentation. After writing the presentation, you can write about the amniotic sac and chorionicity. Chorionicity is monochorionic. In this example, one placenta is shared by both fetuses. Amnionicity: monoamniotic. Both fetuses within a single amniotic sac. No intertwin membrane visualized. So this is a monochorionic, monoamniotic twin pregnancy. Then you can write about the fetal heart rate. Heart rate of twin A is 145 bpm and twin B is 142 bpm. Normal sinus rhythm. Then you can write about the fetal biometry. Starting with twin A, all the biometric parameters are within normal range. Then the biometric parameters of twin B are written. In this example, these are also normal. Both fetuses are growing concordantly with no significant growth discordance noted. Growth discordance is 2.3%, which is normal. Then you can move on to amniotic fluid. Adequate amniotic fluid volume present for both twins, shared sac. Maximum vertical pocket is 5.2 centimeters, which is normal. Then you can write about the placenta. Single placenta located anteriorly, no evidence of placental abnormalities. Next, the Doppler studies are written. Umbilical artery Doppler for both twins in this example is normal with normal and diastolic flow. After that, you can write about the middle cerebral artery Doppler for both twins. The Doppler studies were normal for both twins. No evidence of twin-to-twin transfusion syndrome or abnormal Doppler findings. Cervical length is 35 millimeters, which is normal. You can continue by writing about fetal anatomy. In this case, fetal anatomy was normal for both the twins. Fetal movement. Both fetuses demonstrate normal movements and tone. This is the impression of normal monochorionic monoamniotic twin pregnancy. Both twins are viable with normal growth and development for the current gestational age. No evidence of twin-to-twin transfusion syndrome, no structural abnormalities identified in either fetus. Placenta appears normal, adequate amniotic fluid volume with normal fetal Doppler studies. Continue with regular monitoring, including serial ultrasounds every 2 weeks to assess for twin-to-twin transfusion syndrome and other potential complications. Now we have a report for normal monochorionic diamniotic twins. This is the report. Findings: amniotic sac and chorionicity. Chorionicity is monochorionic and amnionicity is diamniotic, two separate amniotic sacs. Thin intertwin membrane visualized between the twins. Amniotic fluid. The MVP is measured separately for both the twins because there are two amniotic sacs in this case. In monochorionic diamniotic fetal twin pregnancy, both the MVP values are normal. Placenta, single placenta located posteriorly, no evidence of abnormalities. Some normal findings are omitted to avoid repetition. You can follow the pattern of the previous report, which was a full obstetric ultrasound report regarding twins. Impression: monochorionic diamniotic twin pregnancy, both twins are viable with normal growth and development for the current gestational age. No evidence of twin-to-twin transfusion syndrome, no structural abnormalities identified in either fetus. Adequate amniotic fluid volume in both amniotic sacs with normal fetal Doppler studies. Continue with regular monitoring, including serial ultrasounds every 2 weeks. This is a report for normal dichorionic diamniotic twins. These are the findings. Chorionicity is dichorionic, two placentas present which are fused. Amnionicity diamniotic, each fetus within its own amniotic sac. No intertwin membrane disruption noted, both sacs clearly visible. Amniotic fluid, the MVP values for both the twins were normal. Placenta, fused dichorionic placenta located anteriorly. No evidence of placental abnormalities. This is the impression: dichorionic diamniotic twin pregnancy with fused placenta. Both twins are viable with normal growth and development for the current gestational age. Nuchal translucency measurements within normal range. No structural abnormalities identified in either fetus. Fused dichorionic placenta appears normal. Adequate amniotic fluid volume with normal fetal Doppler studies. Now we will look at pathologies. The first one is vanishing twin. Gestational age 9 weeks and 2 days. These are the findings. Gestational sacs. Two gestational sacs are visualized. Sac A collapsed and irregular, consistent with vanishing twin syndrome. Sac B contains a viable fetus. Fetal viability: Sac A, no viable fetal pole detected. Collapsed sac with irregular margins, no cardiac activity or movement visualized. Findings consistent with a vanishing twin. Fetal viability: Sac B, crown rump length is 23 mm, corresponding to 9 weeks and 2 days gestation. Fetal heart rate is 170 beats per minute. Yolk sacs: Sac A, yolk sac not visualized, consistent with resorption. Sac B, normal yolk sac seen, measuring 3.5 millimeters. Then you can write about the uterus and adnexa. Uterus anteverted, normal in size and echo texture. No significant free fluid or adnexal masses detected. Ovaries appear normal in size and morphology. This is the impression: viable single intrauterine pregnancy, Sac B, at 9 weeks and 2 days gestation. Findings consistent with vanishing twin syndrome in Sac A. No viable fetus or cardiac activity in Sac A, and the sac is collapsing. No other abnormalities noted. This is a report for twin-to-twin transfusion syndrome stage 1. These are the findings. Fetal presentation. Twin A, which is the recipient twin, it is cephalic. And for twin B, which is the donor twin, it is breech. Chorionicity, monochorionic, and amnionicity, diamniotic. The fetal heart rate in both the twins is normal. This is the fetal biometry in twin A, the recipient twin. All the parameters are corresponding to 25 weeks. This is the fetal biometry in twin B, the donor twin. The BPD and HC correspond to 24 weeks. The abdominal circumference corresponds to 23 weeks. The femur length corresponds to 24 weeks. The fetal biometric parameters are short for gestational age, which was supposed to be 25 weeks. Amniotic fluid in the recipient twin, polyhydramnios is noted with a maximal vertical pocket of 10 centimeters, and in the donor twin, oligohydramnios is seen with MVP of 2 centimeters. This is the umbilical artery Doppler in twin A. SD ratio is 3, which is normal. Pulsatility index is normal, 0.9, and diastolic flow is present and normal. MCA Doppler, the middle cerebral artery in twin A, the PSV is 40 centimeters per second, which is normal. These are the Doppler findings in twin B, umbilical artery Doppler. SD ratio is normal, pulsatility index is normal as well, and diastolic flow is present and normal. MCA Doppler, peak systolic velocity 55 centimeters per second, mildly elevated, within upper limit of normal range, suggesting early signs of anemia. There is evidence of mild growth discordance. Growth discordance between the twins, approximately 24%. No structural abnormalities in twin A and B are noted. Fetal movement. Both twins demonstrate normal movements and tone. This is the impression, monochorionic diamniotic twin pregnancy with stage 1 twin-to-twin transfusion syndrome, twin A, recipient twin, polyhydramnios, and normal growth with no structural abnormalities, twin B, the donor twin, oligohydramnios, mild growth restriction, and mildly elevated MCA Doppler velocity consistent with early twin-to-twin transfusion syndrome. Doppler findings, normal umbilical artery Doppler for both twins, mildly elevated MCA Doppler PSV in twin B donor, suggesting possible early signs of anemia. No evidence of abnormal Doppler findings such as absent or reversed end diastolic flow in the umbilical artery, suggesting stage 1 twin-to-twin transfusion syndrome. Adequate cervical length, no signs of preterm labor. Recommendations: serial ultrasounds every 1 to 2 weeks to monitor for progression of twin-to-twin transfusion syndrome. This is a report for stage 2 twin-to-twin transfusion syndrome. Gestational age 22 weeks plus 5 days. These are the findings in twin A. Presentation cephalic. Heart rate is normal. Estimated fetal weight 700 grams. These are the findings in twin B. Presentation breech. Fetal heart rate 160 beats per minute. Estimated fetal weight 420 grams. Amniotic fluid. Twin A, recipient, deepest vertical pocket or MVP 10 centimeters, which is polyhydramnios. In twin B, the donor twin, the MVP or DVP is 0.9 centimeters, which is oligohydramnios. Stuck twin appearance noted with reduced fetal movement within the constricted sac. Bladder, twin A, bladder observed to be moderately distended, indicating normal renal function and urine production. Twin B, bladder not visualized, suggesting absent or minimal urine production, consistent with the donor twin in twin-to-twin transfusion syndrome stage 2. Normal anatomical survey in both the twins. No structural abnormalities noted. Placenta and cord insertion. Single anterior placenta with no placental abnormalities observed. Central cord insertion is present in both the twins. Umbilical artery Doppler, pulsatility index and resistive index were normal for both twins. No evidence of abnormal flow or reverse and diastolic flow. Both twins show normal MCA Doppler waveforms with no signs of brain-sparing effects or increased cerebral blood flow. Ductus venosus Doppler was also normal for both twins. This is the impression. Diagnosis: twin-to-twin transfusion syndrome stage 2. Twin A, recipient twin, shows signs of polyhydramnios and bladder distension, consistent with increased fluid overload. Twin B, donor twin, exhibits oligohydramnios with stuck twin appearance and absent bladder filling. Doppler study, normal for both twins, with no evidence of abnormal umbilical artery, MCA, or ductus venosus flow patterns. No evidence of fetal structural anomalies noted for either twin at this stage. Now we move on to stage 3. These are the findings. In twin A, the donor, presentation cephalic, estimated fetal weight 400 grams, which falls into 6th percentile. The weight is less than expected. Amniotic fluid volume, oligohydramnios, deepest vertical pocket 1.2 centimeters. Bladder visualization not visualized during the scan. Placental insertion monochorionic, anterior and shared with twin B. This is the umbilical artery Doppler in twin A, the donor. SD ratio is elevated, pulsatility index is increased, and end diastolic flow is intermittently absent. Middle cerebral artery, PSV is normal for gestational age. Ductus venosus Doppler, A wave, reversed flow noted in the A wave. Fetal growth restriction and signs of hemodynamic compromise are consistent with twin-to-twin transfusion syndrome stage 3. Reversed A wave in the DV suggests cardiovascular strain. Now these are the findings in twin B. Presentation breech, estimated fetal weight is 680 grams, falls into 70th percentile. This is for the recipient twin. Amniotic fluid volume polyhydramnios, deepest vertical pocket 10.4 centimeters. Bladder visualization enlarged and prominent. Umbilical artery Doppler, SD ratio and pulsatility index are normal, and diastolic flow is also normal. MCA Doppler, the PSV is also normal. Ductus venosus Doppler, A wave, deeper A wave suggestive of increased cardiac preload. Twin B shows signs of volume overload with polyhydramnios and an enlarged bladder. Doppler suggests less advanced hemodynamic changes compared to twin A. Cardiovascular profile. This is just a summary of the Doppler findings in both the twins. Twin A, the donor twin, reversed A wave in the ductus venosus indicating significant strain on the heart and suggestive of impending or established cardiac dysfunction. Elevated umbilical artery ST ratio with intermittent absent end diastolic flow indicates placental insufficiency. In twin B, the recipient, the deeper A wave in the ductus venosus and polyhydramnios indicate increased venous return and mild cardiac strain, consistent with recipient twin in twin-to-twin transfusion syndrome stage 3. This is the impression, diagnosis, monochorionic diamniotic twin pregnancy complicated by stage 3 twin-to-twin transfusion syndrome. Twin A, the donor twin, fetal growth restriction, oligohydramnios, reversed A wave in the ductus venosus, intermittent, absent, and diastolic flow in umbilical artery. Twin B, recipient twin, polyhydramnios, deeper A wave in ductus venosus. This is a report for stage 4 twin-to-twin transfusion syndrome. Gestational age is 25 weeks, 3 days. These are the findings. Fetal presentation in twin A is breech and cephalic in twin B. Placenta, single monochorionic diamniotic placenta located on the posterior uterine wall. The placenta appears thickened and hydropic. Amniotic fluid, twin A, the donor twin, oligohydramnios with a maximum vertical pocket of 1 cm. Twin B, the recipient, polyhydramnios with MVP of 10.5 cm. Absent end diastolic flow in the umbilical artery in twin A. In twin B, reverse flow in the ductus venosus and elevated peak systolic velocity in the middle cerebral artery, indicative of anemia. This is the fetal biometry in twin A, the donor. Estimated fetal weight is 480 grams. These are fetal biometric parameters in twin B, the recipient. Estimated fetal weight is 800 grams. Cardiac activity, twin A, the donor. Fetal heart rate is 160 beats per minute. Mild cardiomegaly with increased pericardial fluid noted. Twin B, recipient. Fetal heart rate is 170 beats per minute. Cardiomegaly with significant right ventricular hypertrophy. There is evidence of tricuspid regurgitation and moderate hydrops fetalis, including ascites, pericardial effusion, and scalp edema. Fetal hydrops, twin B, severe soft tissue edema noted, particularly in the scalp, abdomen, and limbs. Ascites is present with free fluid in the abdominal cavity. Skin thickness measures 6 mm, consistent with generalized edema. Twin B shows signs of significant hydrops fetalis with evidence of generalized anasarca and marked polyhydramnios. Twin A is markedly growth restricted with a stuck twin appearance due to the severe oligohydramnios. Here is the impression. Twin A, donor twin, signs of growth restriction, oligohydramnios, and absent end-diastolic flow in the umbilical artery, the stuck twin phenomenon is evident. Twin B recipient findings consistent with hydrops fetalis, including significant ascites, soft tissue edema, cardiomegaly, and reverse ductus venosus flow. There is severe polyhydramnios. These findings are consistent with stage 4 twin-to-twin transfusion syndrome with hydrops fetalis in the recipient twin. This is a report for stage 5 twin-to-twin transfusion syndrome. Gestational age 26 weeks 2 days. These are the findings. Fetal presentation in both the twins is cephalic. Placenta, single monochorionic diamniotic placenta located along the anterior uterine wall. The placenta shows signs of thickening and increased echogenicity. Amniotic fluid, twin A, the donor twin, severe oligohydramnios with a maximum vertical pocket of 0.5 cm, consistent with the stuck twin phenomenon. Twin B, recipient, severe polyhydramnios with a maximum vertical pocket of 12.3 cm. Umbilical cord Doppler, twin A, no umbilical artery flow detected. Confirmed intrauterine fetal demise. Twin B, reversed flow in the ductus venosus, evidence of severe anemia and cardiac decompensation. This is the fetal biometry in twin A. Estimated fetal weight is 460 grams. These are the fetal biometric parameters in twin B. Estimated fetal weight is 830 grams. Cardiac activity, twin A, donor, no cardiac activity detected, confirming intrauterine fetal demise. The fetal body is significantly compressed due to severe oligohydramnios. Fetal hydrops in twin B, the recipient, significant generalized soft tissue edema observed. Ascites is evident with extensive free fluid accumulation in the abdominal cavity. Marked scalp edema and pericardial effusion. Skin thickness is increased, measuring 7 mm, consistent with advanced hydrops fetalis. This is the impression. Stage 5 twin-to-twin transfusion syndrome is confirmed, characterized by the intrauterine fetal demise of twin A, the donor, and critical hydrops fetalis in twin B, the recipient. Twin B is in significant distress with severe cardiac dysfunction and evidence of heart failure. Prognosis for twin B remains extremely guarded due to the advanced stage of twin-to-twin transfusion syndrome and the severity of hydrops. This is a report regarding twin embolization syndrome. Gestational age 28 weeks 1 day. These are the findings. Fetal presentation, twin A, demised twin, cephalic, twin B, the surviving twin, also cephalic. Placenta, single monochorionic diamniotic placenta located posteriorly, appearing heterogeneous in echo texture with areas of echogenicity and calcification, likely secondary to the intrauterine fetal demise of twin A. Amniotic fluid, twin A, demised twin, and hydramnios, no measurable fluid pocket. Twin B, surviving twin, normal amniotic fluid volume with MVP of 5.6 cm. Umbilical cord Doppler, twin A, no umbilical artery flow detected, confirmed intrauterine fetal demise. Twin B, normal umbilical artery flow with normal and diastolic flow. MCA peak systolic velocity is elevated, raising concern for fetal anemia. Fetal biometry twin A, demised twin. Estimated fetal weight is 450 grams. Fetal biometry of twin B, the surviving twin. Estimated fetal weight is 1100 grams. Cardiac activity twin A, no cardiac activity detected, confirming intrauterine fetal demise. The demised twin appears macerated with collapse of the skull and soft tissue retraction. Twin B, fetal heart rate 160 beats per minute. Cardiomegaly is present with mild biventricular hypertrophy and evidence of mild tricuspid regurgitation. Intracranial abnormalities, areas of porencephaly are seen with cystic spaces within the cerebral parenchyma, suggestive of ischemic brain injury. These findings are consistent with embolization events following the demise of twin A. Ventriculomegaly, mild bilateral ventriculomegaly is noted with lateral ventricular measurements of 12 millimeters. Other, increased echogenicity in the basal ganglia, which may indicate ischemic changes or calcifications, possibly related to embolic phenomena. Abdomen, kidneys, normal size and shape with no obvious abnormalities. Liver, increased echogenicity, possibly indicative of ischemic changes or infarction. Bowel appears normal, no evidence of obstruction or dilatation. This is the impression. Findings are consistent with twin embolization syndrome in the surviving twin following the intrauterine demise of twin A. Significant ischemic injury to the brain of twin B is noted, with the development of porencephalic cysts and mild ventriculomegaly. There is mild cardiac involvement but no signs of hydrops fetalis at this time. Here is an obstetric ultrasound report regarding Down syndrome. Gestational age is 22 weeks plus 3 days. Indication for ultrasound, routine anomaly scan and assessment for suspected chromosomal abnormalities due to advanced maternal age, and a positive, non-invasive prenatal testing result for trisomy 21, which is Down syndrome. These are the findings. Fetal biometry. The femur length is short. It falls into 5th percentile. Estimated fetal weight is 450 grams, corresponding to 15th percentile. Head and brain. Normal skull shape with no visible cranial defects. Mild ventriculomegaly noted. Lateral ventricles measuring 11 millimeters. Presence of the choroid plexus, thalami, and falx cerebri. No significant abnormalities in midline structures. Face, flattened nasal bridge observed. Hypoplastic nasal bone with a nasal bone length of 2 millimeters. No evidence of cleft lip or palate. Nuchal fold thickness is 7.1 millimeters, which is above normal threshold for gestational age. Thorax, lungs appear normal in size and echogenicity. Heart, normal 4-chamber view. Heart rate 155 beats per minute, regular. Small ventricular septal defect measuring 2.3 millimeters. No other structural cardiac abnormalities noted. Stomach and bladder are visualized in normal positions. Echogenic bowel noted with slightly increased echogenicity compared to bone. Umbilical cord has 3 vessels, 2 arteries, 1 vein. Extremities: shortened femur length, consistent with fetal biometry findings. Bilateral clinodactyly, which is inward curving of the fifth finger, it is observed. Placenta: posterior, high-lying, grade 1. Amniotic fluid volume is normal with AFI of 15 centimeters. This is the impression. The current ultrasound findings are suggestive of trisomy 21 Down syndrome due to the following markers: hypoplastic nasal bone, increased nuchal fold thickness, shortened femur length, ventricular septal defect, echogenic bowel, and bilateral clinodactyly. This is an ultrasound report regarding abnormal uterine artery Doppler findings. In this case, there was persistent diastolic notch seen on spectral Doppler of the uterine artery in the second trimester. In this example, gestational age is 23 weeks plus 2 days. Indication for ultrasound: routine second trimester anomaly scan and Doppler assessment of uterine arteries due to a history of preeclampsia in a previous pregnancy. Only the abnormal uterine artery findings are shown. The rest of the report was normal. These are the uterine artery findings. Right uterine artery, pulsatility index 1.8 with persistent early diastolic notch present. Left uterine artery, pulsatility index is 1.7 with persistent early diastolic notch present as well. Right uterine artery resistive index is 0.66 and left uterine artery RI is 0.64. This is the impression. The Doppler ultrasound shows the presence of a persistent early diastolic notch in both uterine arteries. This is an abnormal finding in the second trimester and may suggest an increased risk of placental insufficiency, preeclampsia, or intrauterine growth restriction later in pregnancy. At present, fetal growth appears to be within normal limits and no other signs of compromise are evident. The patient's history of preeclampsia and current findings of elevated uterine artery PI and diastolic notches warrant close monitoring. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.